1 month. I'm supposed to be a 6 months person because I'm suppressed from 2005. But I have to go every month. That is really destabilizing, demoralizing. We are saying that there is limited loss to follow up. There is loss to follow up and to increased up from last year. There is increased non-suppression. And these are the targets we are working for. But we are not targeting them for information, for the right timing of medication, for the right availability of medication, so that we don't spend so much moving back and forth and worrying lest we are even criminalized because we have an HIV Act that criminalizes intentional transmission. In this country, we still have that. The second level I will talk about is communities as speakers. We all know that when the cuts happened, 8,400 community health workers were laid off. We are a public service that the government has not really recognized and has taken donors to show the government that community health workforce is not only in the health facility, but is in the support groups, it's in the drop-in centers, it's in the safe space, it is in differentiated service delivery. Many of our members who have been speaking, supporting at the community level, have been laid off. It was earning a livelihood, it was providing a service. Both are gone. But I'm glad to say, recently, in the Ministry of Health, Civil Society and Community level associations mapping, we found that a number of those who are still in the communities providing pro bono services are people living with HIV. And our structures are still intact. And that's why I started with saying integration should not lead to disintegration. The community structures, and particularly that of people living with HIV, has stood the test of 30 years of time. It is immobile. You can tell me now to give you somebody in Amudat with HIV or a community member there, an expert patient. I will do it in the next 30 minutes. And that is a structure we think integration should not disintegrate. How do we ensure that as we integrate, we bring the other services, the other community health workers together to fit into existing structures? And I thought that is the definition of integration. We have found that most of those community organizations that had come from Kampala have since evaporated because they don't have resources. But we still see our community support groups, our district forums, our sub-county forums, our support groups, our expert patients still doing that work, mobilizing, educating, holding by the hand to the facility, and remaining in the facility because we live the experience, we live passion. We know what it means to have HIV, an advanced disease. The third level is around contribution. We have done a lot of good work doing home-based care. We have been doing direct observed treatment, and we know that has reduced a bit, but we still do it in an integrated manner. We refer for family planning. We refer for SGBV prevention. We engage with police. We provide nutrition education. We provide adherence support. That is integration, ladies and gentlemen, and in the community perspective. We have champions who continue to champion in the communities on different community groups. We are into water, we are into gender, we are into climate because this affects us. And for us, integration is not just starting. It started a long time ago. Through our clubs, through our support groups, we don't only do HIV, TB, but we go ahead and refer to the facility because that is one of the linkage areas that we need to work with. As contributors, we have our groups, our support groups, which provide psychosocial support, livelihood support, body support, emotional support. Mental health is critical. And I would like to say we are losing a number of our people living with HIV, not because of ARVs, but because of the integration, the way it was brought into place, the way the stop work order happened. People are just wondering, shall we even live? Does our government really love us? How do we ensure that we sustain what we have gained over the last number of years? As implementers, the National Forum of People Living with HIV forum, which I inherited in January, all the money was cut. We are living, and this is just one example of communities. Most of the communities on malaria, on TB, those who are organized, a number of them, they have shut down. They have closed shop. The mapping is very clear. NAFOFAN didn't close. It closed the infrastructure because the building was dilapidated. The lease has ended, so we have to have a secretariat. We are seated at the AIDS Commission, but we don't have space. We are working online. We are virtual, but we are still here talking and working and visible. But we are only saying, what is integration without community infrastructure? What is non-communicable diseases? When people who are living with communicable diseases who would like to support and offer services don't even have where to sit to support the communities to continue the good work. We were doing treatment literacy in over 20 districts. We have motorcycles there, we don't know what is happening to them. We had cycles there, we don't know what's happening. We are no longer doing this work. We have improvised by having weekly meetings. We have every Wednesday 7:30 to 9 to ensure that we call upon our members to see if we can discuss and see what is on ground. And we are using this forum as an advocacy forum. We are using it as a monitoring forum. We are using it as a capacity building forum. We are using it for emotional support, but also for informing each other about what's going on. So ladies and gentlemen, when the stop work order happened and the termination of grants happened, most of the equipment, we were given laptops, motorcycles, we were lucky we retained ours. Many were recalled. What capacity building is that to communities where projects end and equipment, cabins, the only thing they can't take back is stationery. But virtually anything else we have been using in form of equipment, vehicles, they were taken back. So how do we be integrated? Probably the ministry needs to give us some vehicles to use so that we can do the work of public service nature that is not facilitated, but we know that without it, we cannot stand as a system of health until we reach the communities. The system must ensure it embraces communities. We have even been struggling to be in these conferences. The Self-Motherhood Conference, we struggled to be on the speakership on the table. And we are saying, how long are we going to inform ministry that we are mutual partners? We are not fighting. We would like to deliver the same health outcomes because when we are well, the country is well, and we even move to the next level of development.
3 minutes. Ms. Flavia.
Thank you. The third level is experts, and this I'm not going to belabor. We are experts, and we are experts with our lived experiences. Our stories, our experiences inform policy, programming, and budgeting. Is it possible that we are co-opted regularly? It took a while for us to be integrated into the National Advisory Committee on Integration, on the National Task Force. We are now there. We are glad we are. We have participated in the development of the materials. We have, for the first time, been invited to do support supervision and mentorships for facilities. And we have been supported through the civil society arm to do the mentorships. And we are bringing on board person-centered, stigma-free, human rights-friendly services. And for the few places we have gone, it seems to be working. And finally, as communities, decision makers in integration, it's very, very important that we continue to be part of these programs, continue to inform them, continue to guide and also bring the community voice. It is rich. It is not quantitative in nature. It is qualitative and brings a perspective of what is exactly happening. And in that, we do community-led monitoring, where we monitor the services. The recent assessment was very clear. There is still stigma. There are still stockouts. There is still limited involvement in integration at those lower levels, except for a few places. And I would think that we need to work together to ensure that at the center, and we have already said greater involvement and meaningful involvement of people with HIV. We can replace it, greater involvement and meaningful involvement of communities in planning, programming, and budgeting. And then finally, financing. We have been part of the National HIV Financing Dialogue. And last week we had the National Health Financing Dialogue, always arranged by CSOs. That is the 7th. But we are also part of the National HIV Response Sustainability Roadmap Development. And we are suggesting, and it has been put in the roadmap, that we need to see deliberate investment in community system strengthening, where the donor has gone, who had seen our role and our importance, has highlighted it, and government has seen there has to be deliberate investments. And we are calling upon investments in light of social contracting, in light of deliberate Ministry of Health facilitating us and financing us to go to the communities to mobilize. There are people mobilizing. We are not fighting the VHTs or the CHUs, but we know that the work is there. It's too immense for them to do this work alone. We need to add on our communities. The public health role we play, pro bono, is very, very important. But we need to be facilitated to go beyond where we can only walk and ensure that we reach the last mile. I want to thank you, and I end by saying, let us have integration, not disintegration. Work within the existing structures and ensure that we get the joint and mutual health outcome. I want to thank you, but finally, I would like to invite all the civil society representatives in this room to stand up for recognition. Thank you for the work well done during the stockouts, during this phase, and moving forward. Thank you very much for coming.
Thank you very much, Ms. Flavia. Very touching. I could see most of you picking up your hankies. But thank you for stressing those very key ideas. And I believe as I was sitting close to Dr. Stavia, I saw her jotting down some very key elements of response. So right about now, in the next few minutes, I'd love to hear from us. Presentations have been made. It's a discussion on integration. It's been ongoing for quite some time. And I'd love to hear from us if we have any questions. Yes, from around us, and we have an expert panel here that will be responding to some of these questions. I can see some hands, so let's have a microphone go around. That's quite a number of them. Okay, so let's start from that end. I think we'll pick about 7 questions. Yes, brief to the point.
Yes, thank you very much, and very, very brilliant presentations. My name is Nathan Okiror from Bella Foundation, Uganda. And my question goes to Dr. Anna from Ginger Referral Hospital. She presented on integration and their experience in Ginger. My question is, I think you said you have you're running both models, the chronic care model and also the OPD model. Now, when you go to the chronic care model, especially, you're talking about drugs, antihypertensives, antidiabetics. My experience and the experience I had with one of the funders is that Uganda cares to be precise, that they will provide drugs, they get some buffers to support people living with HIV who are getting care. And then they say the challenge was that we can't be able to afford these other chronic care drugs for all patients because they have to account after all. What is the experience in Ginger? Do you get these challenges? Are they providing drugs for everybody? Things like that. I think it's a challenge. And then the other question was that you also said that I think the issues of pharmacy dispensing, that you moved away from the chronic care and everybody now is getting drugs from OPD pharmacy, I think. Maybe I haven't come to Ginger Referral Hospital, but how do you manage that issues of moving from one spot to another? I thought getting drugs from one center would be better, but I don't know how you manage it, that people move from the chronic care and then they get drugs from the OPD section. Thank you very much.
Thank you very much for those questions. I'll pick another from this.
Can I speak as they get a microphone?
Yes, please.
Thank you so much. I am Kamara Daniel. I'm a nutritionist. And my question goes to Ms. Flavia Chomkama. Thank you so much for the good work. We've seen most of the persons living with HIV, they're reportedly having diabetes. And I haven't had anything related to nutrition integration in the HIV clinics, which is very, very important. In the former education, nutrition, and promotion was emphasizing that when you get HIV, you should eat everything. But now it must be individualistic because each patient has their own individual nutrition needs, those who live with HIV. I'd like to hear you trying to do that, Mrs. Chomkama. I want to thank you.
Thank you very much. Allow me, I may have to dictate. The questions are quite a number, and I know we have to go for lunch. Can we have... I am being bribed. Yes, please go ahead.
Thank you so much. Thank you so much. I'm Shalom Kotsabe. I work with IDI and I support South Central Region TB HIV services. Very good presentations, and thank you so much, the presenters. One goes to Dr. Kabone, Jinja Regional Referral. I really appreciate the presentation and I'm really excited about this integration thing, but I'm really worried about the overall quality of care that we're looking at with all this integration. And the other thing, supporting the region, I see, especially in Wakiso district, whereby most of the clinicians were saying that HIV/TB patients were IDI, and all of them were withdrawn with effect from end of September. And we've had a lot of challenges that speak to, one, the medication errors. We talked about people not knowing their regimens, because we really know that it's a good thing we're integrating, seeing patients together with all the silos and everything. But we also know that most of the times the government staff have majorly been in OPD, seeing the malaria, the TB, and the diarrheas and other things in OPD. And then TB, HIV, even if I was in med school, I started them 5 years ago, things are different if I'm not practicing. And as IDI was trying to do the mentorships, the trainings and everything, but I really wanted to find out the effort the government is putting in to really support these facilities with these trainings, because we really see it's a very big problem. And of course, with the dwindling funding and everything, the sustainability from the IPs is also low. So we need to look at the long-term, plan in regards to that, but emphasizing the quality of care that we are providing to the HIV patients. Thank you so much.
Thank you very much. Yes.
Thank you so much, the presenters. My name is Michael Chiyinji from MakCHs University Joint AIDS Program, and I'm the program advisor. My first question goes to Dr. Anna. If the clinics were integrated and the attendance are going low, I'm not sure why they are going back to pre-integration levels. Either some people are moving out, or probably the appointments have been spread out throughout the whole year or something like that. I'm not so sure why the numbers have increased in a certain clinic, but then the attendances are going to pre-integration levels. The second thing is about the integration efforts at certain levels. For example, the harmonization of data management systems. We've had, you have Clinic Master, you have IAFIA, you have Clinic Master, and in the HIV clinic, I guess you're using EMR. Clinic Master everywhere. But in many facilities, there are different data systems being used between the facility and then the HIV clinic. The integration at that level, and also the supply and commodities system. Some commodities were supplied through joint medical stores, and then others through national medical stores. So the integration at that level, have all the commodities gone to national medical stores? And if they have not been there, what are we going to do about the availability in the facilities? Thank you.
Okay, our second last question. So one and then the last one.
Thank you very much, Dr. Raymond. I work with the Ministry of Health. This is for Dr. Stavia, Commissioner. Dr. Stavia, now that we've started integration over the probably about 6 months, is there a possibility of an evaluation probably soon that can inform our scale up, and then going down from probably building capacity to the lower level facilities? or are we just going straight down to the lower level facilities for the integration bit? Thank you.
Thank you. And our last question, yes.
Good afternoon, ladies and gentlemen. My name is Collins Joshua Kabogoza. I am a postgraduate student, Masters Biomedical Engineering, Bara University. Now, mine is not really a question, it's a kind suggestion. I've loved what Ms. Flavia has talked about, and yeah, with something to do with integration and not disintegration, working within the existing systems. Something I would suggest, there are a lot of organizations that we have in Uganda. Some, like she said, are kind of dissolving down because of the funding. But how about we create something I could call a Yuga Aid for the Ugandan people? USAID was from the United States of American people. How about Yuga Aid? And this is something that can be initiated by this scientific community. I understand very many of prominent people are in this room who have the potential to initiate something like this. We create a funding, I would call it a repository of money, probably in different banks or a Bank of Uganda, where we can have a reserve of money that we can use with HIV, AIDS, we can use with tuberculosis. And I understand there are very many businessmen in Uganda living with HIV. They would love to see something like this get off the ground, and they can't get it, at least it's coming from the scientific people. If they don't know about it, they'll continue going to the hospitals, and they will continue getting told that, drugs are out, we don't have them, we are going to restore, and all that stuff. But if we could find a repository, do something like that, probably we could get enough funding that we need from Uganda for the Ugandan people. Thank you very much.
Thank you too. And the millionaires are clapping. So allow me, I'm going to just entertain very brief responses, straight to the point. And I'm just going to go in order from Dr. Anna. Then, of course, Dr. Stavia, you're going to have to be the last one to respond to the multitudes. Over to you, Dr. Anna.
Yes, thank you so much for those wonderful questions. One of the key reasons as to why we delayed to fully implement the integration efforts in the hospital were some of those worries on making sure that we're providing quality care to the patients. So one of the questions they asked about the chronic care and the general OPD, yes, we have, that is the chronic care model. So we have the chronic care clinic that is running where the former art building used to be. We just transformed it and it is managed, that's why we're managing the chronic diseases. Then the general OPD is still there. So we are having 2 OPDs with 2 triages, but we have 1 pharmacy, and that brings me to the second question about the pharmacy, how we are managing. We tried the first method where we were having, the art building had a pharmacy. It had a pharmacy in there. And at first we brought all the drugs that were to manage the chronic diseases, even the communicable diseases, all the different conditions in the chronic care clinic, because the whole point is the patient doesn't have to move from one place to another in order to get the services. But we tried that and eventually we realized it wasn't working, mainly due to the resource constraints of the human resource constraints. We have the pharmacists are few, dispensing those drugs takes a bit of time. So that's why we brought it back, and now we have 1 OPD pharmacy. And that was from the guidance of the pharmacy department. Yes, we had several discussions on that matter, several discussions, but it boiled down to the fact that that was the best decision to make sure that we are using the resources that we have. So we have 1 pharmacy, and that pharmacy, it has, the beauty with it is that it has a waiting area. And that was one of the big issues we had before with the chronic care clinic, because it was catering mainly to the art patients, and the waiting area wasn't so big. But when we brought in the other conditions, that was one of the challenges. And now the pharmacy, the patients, they come after being seen by the clinicians and everything is done, then they come to the pharmacy and they wait from there. When it comes to the drug stockouts, I think I'm going to tackle it with another question as well. For the drug stockouts, yes, we do not have the buffering, for example, like for HIV, but the drug stockouts are there, and it is a very big challenge, I think, in most places. One of the things, and I think you saw the circular which was released for the patient groups, one of those are some of the initiatives that we are trying to come up with, but the drug stockouts are there. The other question was on, yes, yes, the overall care, I've talked about it, the overall care of patients when it comes to the quality of care that we are delivering. Again, that's why it took some time, because we had to make sure, one of the innovations that we did during that period of time, from when the circular came out to the time when we actually fully implemented the integration in the facility, is that we're mainly utilizing the peer-to-peer mentorships, and we were encouraging the clinicians before they were managing particular conditions. You'd find that on Thursday and Friday, people know they come and they manage their patients for hypertension, DM. And that was something that they knew. But you would ask them, and there was a lot of nervousness at the beginning when it came to managing HIV, TB, because the guidelines are constantly changing. It's time out. But yes, okay. Okay, but what we have been doing mainly, that we are doing the capacity building, the peer-to-peer mentorships, especially the peer-to-peer mentorships. Some of our partners, for example, like Uganda Cares, they have also helped in the facilitation of some of these sessions. So it has really been helpful. Then, in terms of the effort that the government is doing in ensuring that the capacity building isn't just done at the regional referral, but also in the district as a whole. Yes, we do have some limited resources, but with the few resources, again, that is one of the key issues of integration. If someone is going out and they are carrying out a support supervision, maybe they have gotten money from the malaria department, nothing stops an expert from another department to join them. That is one of the things that we are trying to emphasize. Recently, the pediatric team was working with the OBGY team. So we have to use the resources that we have for now, and we make these different innovations. If you're going out to carry out, if you're going out for the CAS campaign and you're talking about TB, nothing stops you from talking about the other conditions and carrying out the different messages, because you have the platform. So that is maybe the message that I can put out there, that as we are integrating the OPDs and the pharmacy, let's also integrate the messages that we are carrying out in the community. This will also integration of the different departments. If you have fuel to go to a district and you're going for a pediatric, maybe you're going to talk about sickle cell, you can also talk about another condition as well, and also invite the expert to go with you. Yes, thank you so much. Oh, sorry, just the one for the IAFIA and clinic master. Yes, IAFIA is in the district's, clinic master is at the general, is at the regional referral. Yes, the systems, I think the ministry, someone else from the ministry will talk about it further. But yes, they have been very beneficial in management of our data. Yes, thank you so much.
Yes, Flavia, 1
Thank
minute.
you. Thank you very much. I think I had only one question, another compliment about financing. The issue of nutrition, the detail about integration will be discussed by the ministry, I believe. But as communities, in our usual work of treatment literacy or treatment education for communities we engage with, the manual, the treatment literacy manual, has got a section on nutrition. So we also do sensitization in our usual work around nutrition. And of course, in light of also the poverty-stricken communities that we work with, it's sometimes a little bit difficult also to take the medication or treatment, not only for HIV, but even diabetes and other diseases. They require that you have adequate food and nutrition. The one thing I didn't speak about was around, in this integration, this is just the final one which I had missed, is around those places where there are many centers of excellence where we get treatment who have not been integrated. And we also realize that it is becoming problematic. We see constant stockouts. And then the other one is the private not-for-profit, where we were getting treatment. We saw the cost of getting medicine from there skyrocket from 2,000 we were paying to, in some places, 10,000. For nevirapine, sometimes it was 20,000, and we even had extreme cases where we were asked to pay subscription of 50,000. So how do we do that? Then finally, in light of data migration and digital processes, how do we ensure that this integration does not leave out the stories and community data? We are doing CLM. How is it integrated? And also on the recipient side, we have had cases where we have to wait for electricity and internet to get on for the queues to continue moving, because people are tired of writing. They don't want to write and then enter. So how can we have this integration offer great or ready electricity availability as well as internet connectivity? Because, and also maybe working offline. How long are we going to be standing in the queues as we await for electricity? And sometimes we are told, go back, come tomorrow when the electricity is back. So there are lots of things happening. It is good, integration is good. Over 80% or 90% could be accepting, but mainly in public health facilities, because that is possible. But where we are in different clinics that are not public, we have not had guidance on how to move from there to go to the general clinics. And then all of a sudden we are told, come and pick your medication. We go for a month, you have a stockhouse. You go for 3 months, you have a stockhouse. So it's really challenging. Integration
you.
is good, but still has limitations, and we need to interrogate most of these things that we are raising from the community. Thank you.
Thank you. You've raised more questions for our commissioner. So over to you, Dr. Stavia.
Okay, thank you, fellow panelists, and thank you, team, for the interactive discussion. We have moved on this integration agenda as we learn, and all of us are key to make the integration a success. The good thing is that we've been convinced that you actually think we should go person-centered care to improve the way we are managing our conditions. But we also need to be cognizant of what we have been having as challenges even before integration came. Now, I seem to hear some of those coming up here as if they have just, we used to have stockouts, didn't we? I don't think that is because of integration. Integration has not brought more people in the country or in the catchment of the district, in the catchment of the facility. So the reason why we're having stockout cannot be integration. There must be another reason, which we need to address together to make the integration experience better. If it is funding issues, we need to all advocate for resources to have adequate funding for commodities for our people. If it is a planning issue, then we need to address the planning and acquisition of medicines from where they are kept. For the recipients of care who have not had their respective regimens, I don't think it is because of the stop work order even, or it means there was an issue in our planning process for these commodities, which I think we need to continue to work with us, you advocate with us to make sure that there is smooth planning for the commodities that we need for our people who require care. Issues of now electricity and the data systems. The issue could be because we have gone digital, but the issue of electricity is a long-standing what? So we need to work together with the Ministry of Energy to make sure that we have better connectivity for electricity and so on. So there are some general things which you need to take cognizance of that have not been brought about by integration. If you said waiting area, increased maybe workload, those can be part of the discussion of the integration, and we see how to address them using the quality improvement approach like the colleagues in Ginger are doing. Someone asked about the evaluation. Like I have said, this integration process is a learning process. And in learning, you have to document every step from the beginning as we move. As I talk now, I think the team of School of Public Health is conducting an evaluation mainly on HIV integration. And thanks to the Global Fund, I think they are supporting that process. But we also have other people who are interested in supporting the documentation around integration. And every time the facility assesses itself or we go out to supervise, there's an assessment that is done across the domains for service delivery. And that information is available. The dashboards are requested the people who are managing to make them public so that people can understand how the process of integration is going. Have we integrated the supply systems? Yes, for public, we know national medical stores. And for private, we know joint medical stores, and the supply of the commodities, I think, has been largely integrated with that arrangement. We really take note of the nutrition integration with people-centered care. When you meet a person, there's nothing you miss out. We know, for example, that nutrition affects a number of conditions. HIV, like you have said, if you are malnourished, we know that you are easily going to get TB. Both if you have overnourishment, like you have diabetes, you are more prone to TB. If you are undernourished, now malnutrition, undernutrition is the key driver for TB, you're still prone. So the integration for nutrition is mandatory. It is automatic because it is a determinant of the disease states, but also it helps us prevent some of those diseases. So we need to work together. Like I said in my communication, the business you are doing in nutrition is about preventing non-communicable and communicable diseases, but also making sure that the children who are being delivered, the mothers, are in good nutritional state. That is the business in the nutrition spheres. So we need to work closely to make sure that that happens. The stigma that is loaded with HIV is real. But we also need to be aware that even non-communicable disease, actually there is more stigma with non-communicable diseases than HIV. No, someone is saying no because of, you've been there both. It was easy for you to, no, but there is a lot of stigma with most of these conditions, but I really appreciate the HIV stigma. I know what it means. Now it is even much better. Before it was very bad. Thanks to the advocacy and the communication we have put in together with you. HIV program, I hope you are listening on the refills. Where there are medicines, I don't think the amount of refills should change, but if they are not there, we cannot give you 6 months and your colleague cannot get a supply. We need to understand if there is limited stock, we need to use what is available to serve all the people. So if we give you 6 months, your colleague who will come will not get any supply. Maybe that is what is causing that, the stock constraints. Anything else? I think that is what I can pick from what remained. The data systems are being worked on. It is taking time, but I think we will get there. The funding. we have to advocate for funding. We
So
have to increase our domestic resource financing for the health services. Thank you.
Thank you very much, Commissioner. Come on, let's clap for them. As we end this discussion, I want to say that integration is a pathway to a Uganda where patients must not be able to choose between receiving hypertension treatment or HIV treatment or treatment for TB, but where they get a full package of services in one visit. And so for us, the vision is one visit, one client, one visit, an integrated package of services for them. And this is my parting shot to all of us. Integration is not really a cost-cutting strategy, as most of us actually may be looking at it. It is a smart investment in system resilience, equity, and sustainability. And so I want to call on all of us, whether you are a healthcare worker, a delegate from the Ministry of Health, a partner in the House, but also members of the public, that integration is the way to go. And trust me, it is going to deliver more than what our patients were previously receiving. Thank you very much for your patience and for your time. During the break, we can be able to answer more questions. I believe all these panelists will still be around. Thank you very much. Allow me to hand over to our chair. So our panelists, you can take your seats. Thank you.
Thank you, Dr. Hudson. Colleagues, a big hand clap to the last session. They have discussed quite a number of issues, and we request that this is not the end. Like Dr. Kazora has mentioned, we have a secretary that is keeping some of the issues. Please, if there's a burning issue, note it down. We shall find time to have it addressed, even during the course of other days that are coming. So for now, our lunch is ready, and it's going to be served at the Sunseed Hall. Once you move out, the ushers will direct you. And we request that you take care of your property, much as we shall have a team to stay behind to look after it. And again, please move with your lunch voucher so that you are able to be guided. Thank you, and let's try to keep time. We intend to start the next session here by 2:30. So we have about 40 minutes to finalize with our lunch. Thank you.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the MakCHs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
this conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of McChs University and especially jointly with the Ministry of Health, because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with McChs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned. We have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the McChs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
this conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of Makerere University and especially jointly with the Ministry of Health, because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with Makerere University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the Makerere University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of McChs University and especially jointly with the Ministry of Health, because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with McChs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination app.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the McChs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
this conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of McChs University and especially jointly with the Ministry of Health, because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with McChs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the McChs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of McChs University and especially jointly with the Ministry of Health, because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with McChs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned. We have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the McChs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
this conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of Makerere University and especially jointly with the Ministry of Health, because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with Makerere University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination act.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the Makerere University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of Makerere University and especially jointly with the Ministry of Health, because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with Makerere University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the Makerere University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of McChs University and especially jointly with the Ministry of Health, because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with McChs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases stakeholders and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned. We have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination act.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the McChs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
this conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of Makerere University and especially jointly with the Ministry of Health, because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with Makerere University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned. We have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the Makerere University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
this conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of McChs University and especially jointly with the Ministry of Health, because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with McChs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases stakeholders and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination act.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the McChs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with education. Thank you.
this conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of McChs University and especially jointly with the Ministry of Health, because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with McChs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the McChs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities.
Sound. Good afternoon, ladies and gentlemen. You're welcome from the lunch break. Time is not on our side, and we are going to go for our third session for today. The presenters and the panelists for the third session are already with us in the room, and also the session chair is with us. This being an afternoon session, we request that we observe time so that we are able to achieve the objectives of today and the sessions that we had planned. Mr. Kato, Sulaiman, and the team, you can close the doors behind and let the ushers get in the people in the room so that we can take our seats and focus on the next session. So our afternoon session is going to be looking at issues of mental health. And to take us through this, we have a team from the ministry and a team from the key stakeholders in this area. They have prepared a panel that is going to discuss key issues, but also a keynote address to open this discussion and presentation for the afternoon. So without going any further, I would like to call upon Dr. Hafsa Rukwata. Please request that you step forward and you take your seat at the podium. You can give her a clap as she comes up. So doctor, you'll come here and you invite your panel and your keynote speaker to take us through this afternoon session. You have up to 4 p.m. That's approximately 1 hour before we go into the next session. Thank you.
Thank you very much, Mr. Michael. Good afternoon, ladies and gentlemen. It is my pleasure to welcome you back from lunch, but also to see you all here. In our world, in the mental health world, we usually see many people who work within mental health, Butabika Hospital. So we rarely see people who are outside those circles, but you're all very welcome. I understand with us we have some DHOs, the COWs, and directors of hospitals, and many other distinguished ladies and gentlemen. I'm so happy to have you here. We are going to discuss mental health, and our theme today is breaking the silence, advancing mental health awareness, and building resilience. We all know what is happening in our country. Everyone is breaking down every other day, and we are all having issues, but just keeping quiet with those issues. I think it's time we broke the silence. So I'm going to have a panel with me. But before the panel comes, I think we shall listen into the keynote address, and this is going to be said none other than Dr. Rachel. Dr. Rachel, where are you? Yes, you're going to be welcome. And after Dr. Rachel speaks, we shall listen in from one of our distinguished judges of one of the judges of the High Court. And I'm sure the room will be joined by some other big dignitaries from different sectors. So I would like to take this opportunity to invite you, Rachel. We don't have a lot of time on us. They've given us just 1 hour. So I don't want to spend a lot of time talking. So we would like to see our presentation put out here. Juliet, where's our presentation? It's coming? Okay, so. Okay, Dr. Rachel is going to introduce herself better. I cannot do it any better, but she's coming from the McCHs University School of Psychology. So she's going to give us the keynote address. Thank you. Rachel, you're welcome. We have 1 hour. We have just 15 minutes for the keynote.
Interesting, 15 minutes. Okay, we will do that. Good afternoon, everyone. Very welcome back from lunch. I'm wondering, are there more people coming in? Okay. I know usually the transition from lunch takes some time. So, is anyone helping me with the slides, or I have to do it myself? Julie? Can I move them myself? Yes, I can sit there, I just need to move it. Okay, so my name is Dr. Rachel Nwagaba, just like I've been introduced. I'm from the School of Psychology, that's MakCHs University, Department of Mental Health and Community Psychology. I'm a counseling psychologist by training and practice, and I spend a lot of time teaching, but also doing clinical work. So just a summary, my research areas are there, that's interest, that I really take time. I would like to be, just like in academics, we teach, but also do research and community engagement, and I also do some consultancy work. Oh, that. Is it working? So which one? Sorry. Very good. Okay. So mental health, just like Dr. Hafsa has said, I keep saying that we live in a very good time where we are now thinking about integration. I've been in this field for over 16 years now, and maybe 20, I will say. But I've realized that most of the times we have lived or worked in silos, which has not supported generally the well-being of the people that we serve. So I have a little personal story that comes from my childhood. At about 7 years, I was with my auntie, and she had a friend who was also a very close person to my parents. So she sent me and said, Rachel, can you help me get an item for me? I won't name it because it was quite personal. It's a cloth. And I told her, I don't put it on. And I was a very young child. But when I think back, at that point, for me, I was very interested in really observing human behavior. Because what went through my mind, and I can actually remember, I was wondering, why don't you go get it? Since you're not busy. So think about the children that you spend time with. They're usually thinking beyond what you actually imagine. So over the years, it's been an interest of mine to actually observe behavior, study behavior, pay attention to what's going on around us. So I have a very little mindfulness activity for you. That is part of the work that I do. Just look around the room. If you don't mind, you can actually stand, if you don't mind, and look around the room. Have you looked at the whole room? Okay, you can take your seat. Just have a mental note whereby you are putting down 2 questions that you're going to ask me, that you'd like to ask me, just 2 questions. You can take a mental note or write them, it's up to you. And then 2 things that you are grateful for after you looked around the room. Make sense? 2 things you're grateful for after you looked around the room, and just 2 questions that you may want to ask me. So I have an ask of you today. As we think about the well-being of all the people that we serve, or even the students that we teach, for me, my students are very special because they're people I spend a lot of time with. And I'm usually trying to project them to think beyond being at the university. What else? What are you doing as you move around? Hence, engaging them in a lot of projects. So I would like to ask you to just be present in these few minutes that we have together, so that you look at mental health as is today. Not as would like it to be, but what it is exactly today within our communities. So I know this is generic, you really know what it is, but let me repeat. So mental health refers to the way we think, feel, and behave. And specifically, it's an essential part of our overall well-being, encompassing our emotional welfare or well-being, cognitive functioning, social connections, and resilience. When someone's mental health breaks down, even the simplest thing in life or chore or activity in life becomes very difficult. Doctors, when you give a person medication, as long as their mental health is broken down, they will hide the medicine and they will not take it. Why? Because there's no purpose. Why should I live? But also, there is a disconnection with what is going on cognitively for them and emotionally. So you may keep giving medication, which will spend a lot of money, and the person doesn't take the medication, and you recognize the treatment outcomes are not improving or they're not positive at all. That's back. So why do we need to focus? So specifically, why do we need to focus on mental health today? One, to avoid overestimation of symptoms without data and other related consequences. I am sure you have seen a lot that is going on. There are so many reports. All of us are reporting about mental health. Anyone can come up with statistics and data at any point. So why is it important that the people in this room actually pay attention to mental health? We will be able to avoid the overestimation that happens once we are not controlling what's going on. We need to recognize the difference between what are mild symptoms, moderate, and severe symptoms. Sometimes, so let me give something that I had some time back. 1 in 4 Ugandans have a mental health condition. And many people kept calling me and they were in a panic. What is it? So everyone is not well. Actually, the person reporting could be saying that maybe 1 in every Ugandan has a mild or has mild symptoms, which we can all agree that that is possible given what's going on in a person's life. But we may not actually say that it is schizophrenia or the severe symptoms that are manifesting. So just that consciousness. The other bit, our country is relatively small. So it is not very difficult for us to actually provide services. For some of you that have traveled, which I know it's a number of you, you have found way bigger countries. So even our own country could be just like one of the states in some other countries. What does that mean? There is hope that we can actually pay attention to the details of what's going on in the different parts of our country because we can reach it. It's also important for us to consider the consequences of co-occurrence of mental health conditions, addictions, and physical ailments. So what we appreciate is the past research always showed us that separate mental health, separate physical conditions, separate addictions. What we see a lot now in the research, actually, if you are assessing for mental health, you need to be assessing for addictions. Why? One can actually lead to the other. I will take a drug to self-medicate for my mental health condition. So you may see me at the bars every evening taking a lot of alcohol, not actually because that's what I'm choosing, but because I'm trying to self-medicate for an anxiety disorder or for a depressive symptom. So just to be alert to that. And then for us, when we are doing assessments, the first questions we want to be asking, is there a medical condition? So we ask our clients, we want to pay attention to that. Are you seeing a doctor? What are they saying? So that if there's a medical condition, let them first go to the doctor. Just paying attention to those details. So co-occurrence is critical, and we need to be aware of that. We also need to see, which we already know, the impact of the COVID-19 pandemic and mental health. That brought us a whole array of new issues, or maybe what was already going on that we were not aware of. But now we had more time to actually concentrate and look inward. So post-COVID, we cannot ignore mental health services or support. Another bit, we have a very young population in Uganda. 75% are below 35 years. What does that mean? A lot of hope that we can actually work with a population, that is alert, attentive, that that we can engage with. The negative aspects are they are very easy to influence. Okay, so we have to be alert to their needs, and they have a lot of dreams. I just gave you a picture of the dreams of a young person. They are diverse. When you see them move, or the stories they will tell you, there is just so much going on in their minds, and they have a lot of possibilities. They imagine that they can do so many things. So we need to be alert to that as we think about mental health. Why? Because that can actually draw them in places of disappointment or frustration when they don't get what they think they should be getting quickly. And the challenges that come with just growing up and just living life. So those are some of the causes of mental health, especially among adolescent school-going children. I just collected some, there are a lot more. When you look up there, I'm sure there are many that you can relate with, that you've observed, but also research gives us a number of those, and the work we do with young people as well. So today, even as we focus on the younger individuals, think about that, because some of these are in your home. One that I would want to speak about strongly is sleep deprivation, because it is something with us. Many of our young people sleep for a very short time, not the 6 to 7 or 8 hours that are recommended, or even some 10 hours. Children are on the buses at 5:30 a.m. in the morning. They get back home at 7 or 8 p.m. and they have homework. And then they go to bed maybe at 10 or 11. Maybe they're waiting for mommy and daddy to come. So some of them actually wait. So when you look at, especially as they go through school, those in boarding school, I'm sure you've had, they wake up at 4 or sleep, 2 hours, they are reading. There's a lot of reading going on. I don't know whether that's how we read during our time. I now also talk about myself that way, because I'm older than them. So just to think about those who have schools in this place who can influence the education system, sleep is a big deal, and that's a time bomb for us. There are many other things going on, pressures, academic pressures, abuse. We see a lot of that going on, despite the fact they're saying no caning, but there are other ways of abusing children that are growing in our society. Neglect, we work many or long hours, hence children feel neglected, or they are actually neglected. So just paying attention to some of these things, recognizing that their mental health could get at risk because of some of these challenges. So I just wanted, this could be, I know it's something that people in this room, I'm preaching to the converted. You already have this information. Mental illness does not leave us the same. Our brains struggle once there's a mental health condition. And I just wanted to make sure I bring that image there. There are many images. You can go online and you'll find them. Parts of our brains get damaged as long as there's a mental health condition that is not diagnosed, that is not being treated. Medication supports the healing, and you'll actually see the brain heal, and the gray matter that is being lost because of a mental health condition starts to grow again, and it looks better. So let's pay attention and recognize that when you hear, whether it's a mild condition or moderate or severe, and you won't see it because it's in the brain. We are seated here, we can't check each other's brains. Once there's a condition, it keeps on getting worse. It doesn't get better unless there's treatment. So I just wanted to emphasize for those of us that are here, that are policymakers, just recognize that the 45 plus million Ugandans, once people are not treated, even if you keep treating all the other diseases, the brain keeps on degenerating. Let's talk about addictions. Remember, co-occurrence, comorbidity. Once there is an addiction, the executive functioning of the person or the individual keeps on degenerating. That's actually damage that we see. through an MRI. It will show us what's going on in the person's brain as long as they have been taking drugs or substances. Also behavior addictions, let's pay attention to gambling. It's also an addiction. And you know that sports betting centers are everywhere. That has an impact on the person's brain. So it's observable, but through an MRI. So if we know individuals that are struggling with these conditions, there will be a distraction over time. Some statistics for us by people who are seated in here, colleagues, ourselves, just showing us what do we have currently in terms of mental health conditions. So some colleagues there came up with data that's in 2022 and recognized that 30.2% depression was at 30.2%. Pre-COVID, we recognized that approximately 22 to 25, that's where we were in terms of mental health conditions. During and after COVID, we can see a rise, 30 to 32% or more. And then we need to also see, Uganda brings in so many refugees. Among the refugee population, it's higher. And we have a record of 67.6%. But also, we realize that there are among children, 22.9% actually have or struggle with a mental health illness. And that was a report of 2022. Today, I want to just go into our major population of the young people. Those are some statistics available, but I want to take us to even the last one that says that girls and senior students are at a higher risk of mental health conditions. So we can pay attention to that population, but generally it's around 17% and 13.2%. That is for depression and anxiety. The most common mental health conditions among young people is anxiety and depression. That's where they score highest. So as I conclude, I would like to come to a conclusion where I'm going to ask us to just invite you, government, individuals in private sector, engage fully, be open. There's a lot of research. We have so many people that are trained today around mental health. Ask the questions, engage, collaborate. Dr. Hafsa is here, and she wants me to stop, and I'm stopping now. Some recommendations for us: let's increase awareness, integrate mental health services in the primary health care, and reduce stigma. Utilize research to inform our decisions. Recognize the importance of cultural humility and community-based service approaches. And then choose, I'm using that word intentionally, choose to hire professional mental health providers and remunerate them accordingly, because they are all available. It's a choice we have to make. We want to thank you so much. Thank you for making the time. There's a lot more we would have said, but we invite you to interest yourselves in mental health work, and there's a lot available, and we can actually collaborate and keep serving the nation. Thank you very much.
Thank you very much, Dr. Rachel. That was really wonderful. Let's give her another round of applause, please. Dr. Rachel, you have not told us why we looked around the room, but we are still here. We still have 1 hour of mental health. And yes, and she's telling me that because to be grateful, there's something that you saw around the room that you can be grateful for. Not the building, not these lights, but even the people, and even yourself, your breathing. Anyway, in the spirit of integration, we know that mental health is a cross-cutting issue. It's not only in health, it is in local governments, it is in your families, it is in your neighbors' homes, and everywhere. For us as a Ministry of Health and as the mental health As the mental health fraternity, we have brought on board the justice, law, and order sector. And the next speaker Honorable Justice Gaswaga is a judge of the African Court on Human and People's Rights at Arusha, Tanzania, and a judge of the International Crimes Division of the High Court of the Republic of Uganda. Isn't that a big person? He's also a fellow of the Commonwealth Judicial Education Institute, Halifax, Canada, and an international resource person in many areas of law. Justice Gaswanga has previously worked as a chairperson of the Anti-Corruption Commission. I know we fear that a lot here in Uganda, but he wasn't here. He was in Seychelles. And he also served as an expatriate judge of the Supreme Court and the Constitutional Court of Seychelles. How many of us have been to Seychelles? Some island somewhere there in the Indian Ocean. You should go there. It's very beautiful. He will tell us, I think. He must have had a time when he was really enjoying that place. His lordship was a distinguished jurist in residence. Do you understand that? We shall know. Distinguished jurist in residence at the CWR, Center for, I forget that one. School of Law in Ohio. There's that university, the Case Western Research University, School of Law in Ohio, and is a visiting professional at the International Criminal Court, ICC, The Hague, Netherlands. Prior to this, Justice Gaswanga was the General Secretary of the East African Magistrates and Judges Association. He has something to tell us about mental health in that sector. Can we warmly welcome the judge to speak to us? I want to be closer, so I'll be here.
I think I'm the one.
Thank you very much, Doctor. Good afternoon, everyone. Allow me to stand on the protocol that has already been established, and so that we can have a conversation this afternoon. I was invited to make a speech, and I'm used to writing and delivering judgments, so I didn't do slides, and I've prepared about 60 pages of my conversation. For us, we are not economical with words like the previous speaker. We have to share those words that we have. So, ladies and gentlemen, it gives me great pleasure to join with you this afternoon. And in particular, I would like to thank the MakCHs, the Minister of Health, and MakCHs University School of Public Health. Thank you so much for the invitation, and Dr. Babirye for always checking on me, and I don't want to say putting pressure because that might amount to something else, but for ensuring that I turn up. I was a little bit engaged and running here and there, especially outside the country. When I was told that I should come and join you, I asked the kind of audience that I was going to meet, and they told me that it's full of doctors and scientists, professors, teaching fellow professors and doctors and so on. So I said, no, this might not be easy for me. And I decided to come with a team of lawyers also, so that we can be able to balance. So for that reason, allow me to introduce part of my team. Some are still coming. With us this afternoon, we are honored to have Madame Anne. Madame Anne Muhire is the Deputy IGG of the Republic of Uganda, Inspectorate of Government. She's here. She's so much interested in the topic.
She wants to know what exactly happens with the issues of mental health, because when she saw the statistics of, is it 1 out of every 4, it worried us that 1 out of every 4, they have some mental health issues. You can count starting from me, 1, 2, 3, 4. That is scary. So those are she wants to know the people she leads. How are they living? What is the effect and so on? So it's important that we get this information. So, Madam, thank you so much for making time. She's a very busy person, but she decided to be with us. Secondly, I came with Dr. Diana Musoke. She's a professor lecturing at the university. She's a lecturer. Remain standing so that they can see your face. She's a lecturer of family law. In other countries, it's called domestic law. Those are issues you know when you talk about family law. And you looked at the causes there, and so on. She deals with issues of divorce, child support, people who are there, and all that. And she teaches and also deals with them. She's the leading lawyer right now in Uganda in issues of divorce and so on. You may be seated. Now, you will know other things why actually we came with her. Then we also have Madam Bako. Madam Bako, could you also stand up? She's also a lecturer at UCU and dealing with a lot of issues related as well. And most interestingly, she's writing her PhD on mental health issues. She's doing some investigation. All these people that you see, the others who are coming, the team is quite big. All those people that you see here, there are certain things I do with them that are in the area of mental health. We are not doctors, but I don't know whether you can call us Kamyufu doctors, I don't know, but something like that. That's why we are here this afternoon. Now, with my 60 pages, I've been given 30 minutes only. I've consumed about 2 so far. So I'll try to be a little bit fast. So in my remarks, I decided to prepare some bit of introduction. Then for my introduction, just talking about mental health, and I can see my sister has already done some good job about the same. I'll try to look out as a lawyer, to look out for a connection between mental health and human rights. And then I'll look at mental health issues in schools and universities and give you a few examples which we are dealing with, then make some recommendations in my conclusion. Before doing that, I want to comment about the theme. I want to commend you for making this is a great choice of the theme, breaking the silence, advancing mental health awareness and resilience, advancing mental health in schools and universities. It is said that a problem shared is a problem halved or half solved, something like that, isn't it? The question is, how do we get people to talk about this? I'm telling you because where myself and my colleagues belong, we have even VIPs there and so many other VIPs that we met. They have also children and so on who cannot easily open up for various reasons. So my speech is going to give you a very different, it's going to come from a different perspective compared to a lot of science and so on that has just been going on here. So by advancing awareness, sensitization, and resilience, could that be the thing? Remember, mental health is a preventable disease. That's according to my research. And prevention, they say, the people tell us that prevention is better than a cure. Then the Bazungu say, a stitch in time saves 9. But in my view, if not prevention or elimination, then early diagnosis of any disorder would be the best and the cheapest option. That's for me. You may correct me. For there is no health without mental health. That's my observation. So it was a very brilliant idea that you put all these people under the same roof. I want to thank you so much and commend you for that, because I know that we have researchers, policymakers, we have leaders, and so on, and now even us, the lawyers, finally are joining you. So as a judge, when I speak about the effects of mental health on the population, you know, it scares me a bit. But I speak now from a place of first-hand experience. You know, sometime in 2020, sometime in 2020, an article published by the New Vision, to be specific, I think it was on the 19th of September, 2020, featured my opinion on the need of mental health, social support to judges who face challenges as a result of dealing with the gruesome evidence in some of the cases. And I'll just give you one example. You see, for us in law, I don't know about you so much, but for us in law, everything you say we want evidence. We will call for evidence. So I was training judges, and I mentioned that, we need also support. Because let me tell you, we hear all sorts of things that happen in society. Some of them are so horrible, you will not believe it. They are so horrible. Somebody will come and narrate in evidence how they killed another. A witness will tell you how they saw this one after even being killed, how they chopped them into small pieces and so on. Let me tell you, we've just been dealing with, I was on the panel dealing with the LRA case of Uganda versus Koyelo. I'm sure everyone at least knows something about it. But simply, this case is about what happened in northern Uganda during the Kondi times. And we had all sorts of things. We saw videos of, bodies being exhumed. Witnesses came and they kept telling us how they were forced to commit the murders, the killings, and so on. It is terrible. Young people taken, young girls taken and turned into wives and so on, and just at what age, and we just start imagining, how did this person give birth, and so on and so on. So we had witnesses coming, and after every 10, 20 minutes, after saying 1, 2, 3 words, they break down, the court stops, and those are resources. We are forced to retreat to chambers. Then they go, the experts, we have to bring in experts to work on them and so on. Then they recover. Somehow when they recompose themselves, you move on for 30 minutes, they break down. Their testimony is going to take about 3 or 4 days, one single witness and so on. So I'm talking about my area, our area, with my learned colleagues here. So that is our world. So we decided that, and then we've also noticed that many other professionals too actually are prone to mental health. And I don't think you are also spared. But it is, you are the doctors, but I don't think you are spared. And it is worse actually when you doctors are also affected, because we rely on you. You are the people that are going to, when we fall sick, for me, I just come and throw myself there. I leave it to you. When you tell me swallow this, I believe you. I just swallow. Do this, that's what I will do. So I think this is a matter that we really need to discuss, and that's why we decided to come and join you. And in schools, it's worse. Now, there is no way I can leave this podium without saying something about human rights. So I have to create a relationship between mental health and human rights. And being a lawyer and a judge serving at the African Human Rights Court for Human and People's Rights, I think it would be a disservice if I walked away without making that link. So mental health, I will give my definition. She gave hers, very brief. Mine is about a page. Let me give it to you. Mental health is a state of physical, mental, emotional, and social well-being determined by the interaction of the individual with society. It is therefore shaped by the conditions in which people are born, they live, the conditions under which they work, and cannot be considered in isolation, therefore. And it also means that for them to be realized, you must have a respect for human rights. And the bottom line here is that we must recognize that mental health is intimately linked to a person's socio-economic and physical environment, including exposure to poverty, you see the causes there, violence and discrimination. This therefore calls for a holistic approach, according to me, for a holistic approach. If you closely consider most of the factors leading to depression and other mental health disorders, they stem from human rights abuses and violations. Most, according to me, I'm looking at it with another lens. For example, a student who is still under the care of their parents, they have a right to education, a right to food, a right to clothing, shelter, emotional support, among others. When such needs are not catered for, and at times, due to social pressure in schools and the like, such students may find themselves as culprits of mental health disorders. Therefore, it is crucial to bear in our minds that there is no promotion of human rights in our surroundings. When there is no promotion of human rights in our surroundings, then we have set up ourselves for failure in trying to promote and protect and promote mental health. And if mental health is not promoted, especially amongst the young people, then we stand to lose our future generation. And without being an alarmist, I want to tell you that where we are standing now, the future generation, you may have survived with so many things, but the youngsters are in trouble. We need to double our efforts in helping them out. Now I come to the main topic of advancing mental health in schools and universities. In order for us to understand this better, my sister gave some statistics, but for me, I also want to look at some statistics in addition to hers. I will start with the worldwide. Mental health issues are prevalent among adolescents in school, with rates of 50.2% for depression and 43.6% for anxiety disorder. And she has already said it, anxiety. In Uganda, approximately 24.2% of adults and then 22.9% of children in Uganda, they have a mental illness. Those other terms, I will use them interchangeably, but I know I'm in the right place. You will correct me, but at least you know what I'm communicating. You will use the right terminology. So research carried out by the School of Public Health, where some of you may have been involved, recently showed that girls carried a greater emotional load than their counterparts, the boys. And in addition, they are likely to experience emotional disorders like anxiety and depression again, compared to their male counterparts. This now brings in the gender aspect, human rights and so on, the gender aspect. The latest statistics indicate that 17.6% of children attending school in Uganda are struggling with the depressive disorders, alongside increasing instances of anxiety and insomnia. She stressed that as well. This situation can no longer be overlooked. It can no longer be overlooked. Let's now just have an example, a survey of just Kampala. We have some statistics here to just Kampala city alone. The data from there may be a little bit worrying. And you know data, some people are not captured, but the data that at least was captured. In Kampala city alone, we have 90,530 cases of mental health disorders among students. And this was registered between July 2024 and June 2025. That's a span of 12 months, 1 year. That is what we have. And now, making it a 12.2% increase compared to the previous year. I've told you we are in trouble. 12% increase is a very, very big percentage. The common mental health conditions, let us try to unpack this and see. They include epilepsy, 29%, bipolar disorder, 19%, schizophrenia, 14%, anxiety, 6.6%, and then substance and alcohol use disorder, 6.3%, and depression, 5.3%. Meanwhile, experts have warned that suicide cases are on the increase in secondary schools and higher institutions of learning. The solutions should come from here, nowhere else. There is no Muzungu going to come from anywhere to guide us. Ladies and gentlemen, I have told you that me and my team there, as you see us, we are Kamyufu doctors. We are helping some people there. So we've decided that we should share with you just a few cases. They are live, they are ongoing, and you will advise us. They are ongoing, we are dealing with them. I'm not going to reveal names or particulars or so on, but just the facts. In court, we are not supposed to comment about ongoing cases. In medicine, I don't know. You can advise me, I don't want to be arrested here. You discuss, even reveal the names. Okay, fine. I'm on the right path. Example 1. There is a student who has been taking drugs since senior 2. He's currently in his final year of study and struggling to stop taking drugs. In fact, he also confesses to supply drugs to some students, and the parents are nowhere, are not aware. He also has suicide thoughts, and he has tried to kill himself 3 times in vain. He also says none of the parents know what is going on in his life. The parents pay the fees or the tuition, whatever, and provide him with money, but they are not available, absentee parents, and so on.
it is ongoing. In that case, we are advising him. Pick out the issues there because of time. My 30 minutes, I've so far used 5. I will not engage in more. Second example. Another student has been taking drugs for the last 2 years and is also a supplier of drugs to his colleagues. He says that when he joined the campus, the parents say they would only pay the fees and that the other requirements he has to find himself. He says he had to start supplying drugs as that brings in quick money. But to keep customers, he also needed to start consuming the drugs. He has also tried to commit suicide. And he has also been self-harming in various ways for the last 1 year. In fact, he has scars on his body. We saw them. And his parents are not aware of this. The case of insufficient provision by parents and so on. Issues also packed there. Live cases ongoing. Example 3. One boy had joined a group of S2, a group in S2, and they started taking drugs. They would go out of school and get weed cookies. But because this boy had a very good relationship with his parents, especially the father, he woke up one day and decided he no longer wanted to be part of the group. This was because he didn't want to disappoint his father, who is also his friend. His friend, he claims, he said the father is his friend. This goes to the significance of the relationship we have with our children. As parents, we have to be deliberate with our children and befriend them. To date, one of his friends confesses that the said boy has never taken drugs again. Let's look at the relationship we have with our children. How do we relate with them? Just look at this boy, how he respected his father. Example 4. Some schools have a system of restreaming the learners according to their grades. By the way, some of these things may look small and light and but they have grave effects. This is another case here. Some schools have a system of restreaming the learners according to their grades each term, which affects their self-esteem. The stability of such learners is affected, and sometimes they fail to keep up. In a certain school, 2 students came from the same village, but one of them from a relatively better school and with better grades, and they joined the same class, When they joined the senior one, they were both allocated to the best stream, because there was stream. There was, according to him, he said there was, according to Hatch, he said there was north, east, west, and south, 4 of them. But I think south was, what is west? Oh, that was for people, they don't call them poor students, they call them slow learners, isn't it? Then it boils down to the same thing, but the terminology, being diplomatic, is always good. However, as time went on, the one from the better primary school and with better grades declined in her grades and was eventually shifted to the last stream of poor performers or slow learners. This brought about pressure from her parents, who expected her to do as well as her colleague. Eventually, after efforts to improve were futile, she lost morale, gave up, and settled for the last stream until she left the school. So every other year, she would go to one step back. This learner could not cope with the stiff competition and lost interest in not only the school, but also her studies generally. Like I've told you, and I want to stress, these are live cases. In a court, everything you say must be backed up with evidence. We cite cases, so these are my authorities I'm relying on what I'm saying. But in all this, what are the causes? Why are we there? What are the causes of all this? I am glad my sister here has made my work very easy. So I will just fly over. That may help us save maybe some 5 pages and some 3 minutes, because it is very easy. I can just point out a few: stress in relation to workload, like candidate classes, and also students who are doing courses like law, engineering, medicine, and so on, you see, and coupled with high expectations from parents. Long study hours, you've talked about it. These kids leave very early in the morning and they go, 5, They leave 5:30, the mother and father are also leaving, and then for them, they come back at 7, father and mother coming back at 10 or so, chasing after money and career, promotions, and so on. And this affects them, it deprives them of enough sleep and rest, and affects their concentration, causing even some sleep disorders. Peer conflicts. They struggle in relationships with each other, especially at university, which bring things like bullying, negative teasing, body shaming, even cyberbullying, and so on. All these things are going on. Depression coming from homes, family conflicts, broken families, parents fighting and quarreling in the presence of the children. They say them, all these things, and they've told us. Trauma, childhood traumas, growing up in abusive environment. What sort of environment is your child growing up? If it's abusive, use of drugs and alcohol. This, she mentioned it, and I don't have to explain much about that. And this is going on especially at universities. But they are starting in secondary schools. These kids are buying very expensive bottles of alcohol, which even myself, I can't buy maybe once in a year, birthday or Christmas. But now the other question is, where do they get the money? They're given also too much money. It's another cause. Whereas some are being given too much money, there are some parents who are giving, they have given them pocket money nowadays, weekly allowance of about 1 million. So meaning the kid will have, university students has about 4 million a month. I don't know how much, what the salary scale in your, and whether it is worth for me to go back to school if my parents are giving me that and they have bought me even the best phone that is on the market and that kind of thing. So all these things. But the irony is that whereas that is a cause also, we also had the other one is poverty and, lack of financial hardships, lack of funding is also, another cause on the other side. Yes, then we also have too much use of social media and its influence among the children. Do you know what your children watch as you are here, especially when they are doing during holidays? I don't know whether you know. I don't know how many parents put in some restrictions here and there. But even if you put in, I have a parent who was telling me that she has a son who breaks all passwords. Even when the father's password got, he couldn't remember, he called him in, and within a few minutes, gone. So even when you put some of these restrictions, our children are too sharp. They will bypass all these things. And so what are they watching? And then for how long? You make a journey one of these days and get out of your room at about 3 a.m. and venture and just go to their rooms. You'll find them there watching or communicating with the rest of the world. They are doing things. In this era of internet, things, everything they are doing, So what are our children filling their minds with? And it's very dangerous. Again, let me give you a perspective from court. First, we had recently a case. Of a young boy who befriended a young girl online, and on their very first meeting, he killed her. It's a live case. The lawyers will tell you. I think my sister there was even involved. My sister there was involved in that case, and Justice Mutonyi dealt with it, and then killed her. And when they came back home, they asked, when they said, he told the parents out, and they also saw it because he had dragged the body, and there was some blood and so on. It's a case, it's there in the court. Like I told you, for us, we deal with evidence, So how much time do they spend there, and what sort of stuff do they actually look at? Unmet emotional needs, like you've said, and then there are also these social biases and so on. Big boys, men don't cry. How? But when something is paining you here, me nowadays, I would rather go to my room and cry when people are not seeing me. If it is going to give me some relief, I would rather cry than listening to people telling me that big boys don't cry. You see, because that kills you. Absentee parents, chasing after money, like I told you, career, and so on. We are too busy, hopping from one country to another. We're on this flight and the other one, and then we go back at night and so on. Sports betting, I was surprised. Gambling, I was so surprised. Anyway, let me leave it at that. The causes are just too many. But in all this, there are so many challenges. The absence of a coordinated national response. From my research, I could see that it's quite a challenge. Weak community support systems. People long ago, you would get somebody to offer some counseling services easily. But nowadays it's not easy, even within family, you see? So the system is weak. Lack of data, all these relevant data, all these worsen the whole situation. Others would include low funding, insufficient numbers of trained personnel. I was surprised to learn that we only have 50 psychiatrists in Uganda. I didn't know. The more reason I should be more careful so that I don't get into that, because 50 doctors, the ratio, that means the ratio is 1 to 1 million actually. 1 to 1 million, one psychiatrist, you know, to help 1 million people. Yet, we have already seen some statistics saying that 1 in every 4 Ugandans, then when will the doctor get to you? I'd better remain straight. Then strain on the mental health services, which is facing an increasing number of cases and lack of psychosocial support programs in schools and workplaces. Now, underlying workplaces. When you invited me here and the flyer was sent out, I want to tell you, I received the calls and I received the calls and I received the calls and I received the calls. That goes to you, that's why I'm looking at you. Not only from the judiciary, not only from the legal fraternity, but from so many places, even now. And they complained. They said, I told them, no, mine is confined to children, school children. So they said, no. How about us, the adults who look after them? We are the ones who raise them. We have to be in good shape even before, you know, so we should be able to take good care of them. So out there's a lot of work. We have issues, but I like it when you say from our theme, how do we open up? They are not opening up. And I want to tell you that myself and the people you are seeing there, we are some of the few lawyers, if the only ones to whom people open. But we are also overwhelmed. We don't even earn a salary. We just do it on a pro bono basis, just giving back to society. But how many are there out there that cannot access us? And when I was coming in the car again, I started getting a lot of complaints. They told me, I gave them a link. They said, Judge, the link you have given us, you have really cut us out. We are supposed to pay. Is it about $300? They've told me that to access. And they said, because they wanted to attend online. That means if they wanted to attend online, it means people are curious. They are looking for solutions. There must be something happening in society out there. So this is for us in this room to come up with the solutions and see how we can deal with it. Next time, maybe we shall get a sponsor so that we open up the link and we don't limit them. They will get to know. So, we have all these issues there. If there is failure and refusal to open up, then people will be suffering. People will be suffering, and it will just aggravate the whole situation. Some fear to open up. Another person told me they fear to open up because they will be judged by the public. It's a very big challenge. But not only judging, looking at the causes, others said they might be charged in court. Because, you know, if, for instance, for us in court, if you say attempt to take your life, but the mission fails, now we charge you for attempting to take the life of that person. So you are punished. You see, so that is another fear. So opening up becomes a challenge. And that's why some of them really try to make sure that if they attempt, they must go. But we don't want to lose people. You see? Treatment gap. I was surprised to learn that 75% of mental health patients receive no treatment at all. Is that true? Because they don't come to the facility. But you have everything, the manpower, the medicine, the fund and everything. Okay. So I told you that I will skip some pages. Let me conclude by looking at a few recommendations here and there. Some of them my sister has already given. What should be done in these circumstances? I just have 2 or 3 recommendations to make, very few, because the others have been already put there. And some are specific to academic institutions, our youngsters, but also some are general. One of them on the specific would be sensitization, that we need to sensitize schools and school-going children and university students about mental health. Very little, I will tell you, very little is known out there. Even big people that you would think that they know something, they don't know. anything, or they don't know much, or they just know very little. And so some of them even associated, they fear to come up, they're associated with a clear, or should I say qualified or mental illness. But I've been told from what I've heard that not every mental health challenge actually qualifies as, you know those categories. Let me not bother myself. Me, I take them as the same. Yeah. Can we break the stigma and create awareness on mental health? Teach the children that it's okay, it's okay to be okay and not to be okay. And so that they can be able to speak to us and speak about their mental situation and open up. It's a very, very big challenge. And the other thing is, what we should endeavor to do also to tell people out there is to create a conducive environment that will make them talk. I don't know how we are going to do that, but since we are going to put our heads together, I know we will get answers. Integration of mental health into the curriculum, somebody has talked about it, and starting from lower primary up to university level. Then the policies by Minister of Health, Minister of Education. I know that there are some guidelines that were issued, but the question I have with the guidelines is implementation. Do the teachers know about these guidelines, the lecturers, school administration? How about the students themselves? Do they know about these guidelines? It's important that we bring them at the fore. How about policies on long school hours? Do we have them? Minister of Education? I spoke to somebody from Minister of Education. Long school hours. I know that there's something that one time they wanted to implement, and they said, no, coach, what we call in Uganda coaching. You remember? Everyone wants their, child to go to get better marks, and but then so they have to go for coaching. If you don't go for coaching, you are left behind. How do we balance that? And when the government started actually arresting some school administrators, there was some kind of a riot. And then people would take their children and assist the teachers to break the law by teaching them under, behind their own the bedroom, behind their homes, and so on. But the rules, there are some regulations. Then here, the role of parents. For me, when, much as our children spend more time, say about 9 months or so, 8 to 9 months with the teachers in schools, but we have a very, very big role to play. We have a very, very important role to play here as parents, because for me, it all starts from home. How can parents help us in advancing good mental health amongst these learners? Are they available to monitor and guide their children? You see, we've talked about the cases of absentee parents. Then schools to build a line of open communication with parents. That is very, very important, I'm telling you. Some kids are very good at home. Some of them are even born again at home. But I want to tell you that when they get to school at times, it is something very different. I've lectured before, and I would be surprised. But I also want to tell you from my personal experience, I was not there, but one of my nephews was telling another nephew and friends that, my son, who is at university, was complaining and telling them that Dad has forgotten that I'm at the university. He carries on with VDs even at the university. And look, because I want to know what my son is doing, so I've reduced on the visits now, but I go there and I want to know to some extent. Even on the very first day, I took him to get the room, to time the room which was going to take on and so on. But all was because of the love I have for him, because I want to know. And I always insist, I want to know their friends. And the friends come home. Some of them I even travel with them up to the village. Now, what he didn't know, and he complains that I still think he's still in secondary school, I go to the lecturers. Because all the other, when he was still in secondary, I mark them, I even sign in their books. All of them. You'll find Amagunga, Smack, where I go and check in their books. Much as I fly a lot all the time, but I have that time. I'm telling you, I have it. So I go and check. So that also, and they always tell them when I've already arrived that Your father has come. So when they come, they find him in the staff room. I'm already interacting with the teachers. Now, that has helped me a lot to know a little bit about them and how they behave at school. And they are prevented from, I think, doing certain things because they know that I monitor Big Brother is there, much as most of the time is in the skies, but he knows what is going on. Because I have even phones for that, and I go there. Even those at university, I go and check their work. So, but how, maybe you could borrow a lift since you are clapping, it could be a good thing, but it helps you, but also monitor the friends. So you communicate with the lecturers and so on. But also we may need also to conduct some research in these schools and so that we can know what is going on. Now I want to run to the general recommendations as now I finally get to the end. I looked at the budget that you have and I realized that what is allocated to mental health is less than 1% of the budget for the whole sector, Minister of Health. I wish Dr. Diana was here, I would be looking at her. And then they allocate, all things come when they already, all she has to do is to give you what belongs to you. But also I checked and according to World Health Organization, they recommend 5% of the health sector budget. Do they give it to you? 0.9, not even 1. So what do we do? Here I am. Much as I'm not in the Ministry of Health, but as a judge, I really, really want to appeal to government to look into this and increase on that budget. This thing is eating us. We have to fight it. It's a silent killer. Do not know even the people who are making those allocations. They don't know that they may actually need these services. So it's better that when the time comes when they need those services, you are there to be able to attend to them. So I'm worried about that budget. Then I looked at the element of staffing also. I've already said that, one psychiatrist, 50 of them in the country, to serve 1 million people. I think we need to do much more than that. And I noticed that I think within the framework, we don't have some provisions for psychiatrists, clinical psychologists, social workers, and occupational therapists. I think who should also be even distributed, concentrated in urban areas, but also deep there, because this thing is eating people. Then the public service legal framework for the Ministry of Health in particular, I think there is something there again. They don't seem to define certain roles. Psychologists, psychiatrists, clinical officers, and psychiatric nurses, so that they can be accommodated. Because it appears like when they complete their courses, they go to do other things other than coming to serve us in the sector of mental health. And this can also lead to brain drain. They will be taken away by others because they are on market. They are needed everywhere in the world. I noticed that I think with Butabika, they produce about 500, you call them psychiatric nurses, and then psychiatric nurses, and then 50, what are they called? Terminologies, clinical officers. That's a very good number every year. 500 and then the 50, that's 550. Imagine if they had places within the Ministry of Health so that, and they are distributed in the districts. How many districts do we now have as of today in Uganda? Are you sure? 142. Because they keep growing. You might be here when it's so 142. Quick mathematics, 550 divided by 142. I'm not going to ask lawyers. You help me, the scientists. I will spare them the embarrassment. Yes. How many are those per district? So every year, like that, do the multiple, and then things might change a bit. For me, that's what I think. Those are my views, and I would then multi-sectoral collaboration that my sister has already talked about. So we put our heads together and don't leave out the judiciary. I am telling you, don't leave out the judiciary. We are waiting for you. We want you to come and we have a discussion. Not that we are very, very bad love, but we need you. You come and we need you. I realize I want to end with this one on legal aspects. we have to take note of, as we discuss this topic, that suicide is a medical condition, according to you. But according to me and my sisters there, it is a criminal offense. So how do we deal with it? You will tell me that decriminalize it so that people can come up and open up and, but for me, I'm saying otherwise. So my view on that one would be that probably we should have a debate on the same. Now that lawyers have started joining you here, we should have a debate on the same so that we can have a good. And finally, again, another debate on alcohol consumption. You look at it in a different way, but the government looks at it in a different way. They are looking at the revenue they are going to collect, the taxes. And I remember the president of Uganda one time saying, was commenting, he makes his comments and so on. But then he said in Uganda, now for him, he's looking at it, yes, and for us now, we are looking at it in a very different way. Ladies and gentlemen, thank you so much for listening to me. I'm happy to have been with you.
Thank you very much, Justice Gashwanga. The chair was burning me, and I stood up and sat again. I think we're not doing very well with time, but I think you're going to give me another 10, 15 minutes, just that. Yes. So kindly, let's put our hands together for that. I'm calling these ones the new kids on the block for in the mental health world, because I think they're going to be ambassadors. They're going to help us to talk. For us, we don't know how to talk. We just say things, this is the number, I have anxiety, there's schizophrenia, there's this, and then I keep quiet. But now I am hearing another voice putting it in another language. I'm so happy that this is happening. Colleagues, ladies and gentlemen, that was the judicial's mind telling us something to do with mental health. We are in the health sector, but doing very poorly in mental health. How many of us here, district leaders, have a mental health focal person in your district? Just put up your hand, please. I'll be happy to see that person. You see? There are very few. We have 142 districts and about 20 have focal persons. But it is in the law of 2019 that every district should put in place a mental health focal person to be able to coordinate mental health services in the district. For those of you who are here and you do not have a mental health focal person, we badly need one because the mental health status of Ugandans is not okay. We need to purpose to do something differently. First, we have talked. We have told you the figures, we have told you the science, what is in there, but we are keeping quiet. Can we break the silence? Dr. Kalani, come over, we have 15 minutes. Let's get a panel. We're going to receive some people who are going to talk about just a few things. The theme is breaking the silence and building resilience within our communities. We have poor mental health in our workplaces, colleagues, ladies and gentlemen. Can we do something? We certainly have to do something. The previous speakers have talked about education. Education, yes, it is badly there because the population is highest in that side, but the workplaces are doing so poorly, and you are the sole providers. Dr. Kalani, kindly introduce the people.
Thank you so much. Let's clap for Dr. Hafsa. Her passion for mental health is palpable. She forgot that she was a session chair and, and went on to give the speech. So, the interest of time, we have, I'm going to chair a panel of 3 people, and the intention is to advance the discussions that we've had from the previous speakers. I must say, it gives me so much joy to listen to the judge of High Court of Uganda talk about mental health in the way that you spoke. Thank you so much, and I think that is the true definition of multisectoral integration of mental health, recognizing that mental health is a cross-cutting issue. So ladies and gentlemen, allow me invite Miss Harriet Abe, Dr. Harriet Abe. She graduated with a PhD. How many days ago? 3 days? 2 days ago. She's a fresh graduate. So Dr. Harriet Abe is a research fellow at McCHs University School of Public Health, and she is going to give us a picture of the burden of substance use amongst young people in the country. Where's Dr. Harriet Abe? Okay. So I hope her presentation is up. We have about 7 minutes to present this. So over to you.
Yes, I'll just rush to the findings.
All right.
Hello, everyone, and it's a bit surreal to be here, but I'm very excited to be here to share with you some of the findings of the TREAT Consortium, where my work is a part. So right there, you can see that we have a very big team that's been looking at substance use among children. What does this work? Okay, so since I have only 5 minutes, I would like to observe all protocol and go straight to the point and build on what the justice left as his last remark, and that's looking at substance use. So for the longest discussion, most of the focus has been on adolescents and young people in universities, but under the TREAT Consortium, we found that there was much earlier use, and so our research is focusing on much younger children. Yes, please.
Your point here.
Oh, sure. Thank you. Thank you very much. So as part of our methodology, we had a mixed method study that looked at adapting a child-appropriate tool to screen for substance use among children as young as 6 years of age. And this was built on evidence that showed us, I think around 2019, that children as young as 5 years were already consuming alcohol within the Eastern region. And so we wanted to quantify the burden of this problem. And so we did a study in facilities, in school settings, as well as in the community. So within the facilities, we found that 1 out of 4 children that came to facilities that were aged between 6 to 17 years actually reported some form of substance use. And when I say substance use, I don't mean a little sip, a little accidental use, but actually intentional use. And within the school setting, still about 1 in 4 children who were aged between 6 to 13 years were using substances. We also found within the community that about maybe 1 in 5 children were using substances within the community. But overall, about 7.2% of the children who are aged between 6 to 13 years met the criteria for dependence. That means that you could characterize them as those that have severe use. So when it came to finding out what's leading these children to use substances, who was initiating them, if at all, any, we found that it was mostly the exposure at home. So for alcohol, most of that exposure was happening at home, among peers, just as was stated earlier, but also this use was linked to adversity, that is separation of parents. Children who had lost a parent were more likely to be users compared to those who hadn't. Additionally, there was also the element of curiosity. So among the substances, you can see the ones I've mentioned above. The most prominent one is alcohol. And then when it came to access, how does a 6-year-old access alcohol, if at all, we found that alcohol in Mbale was so easily accessible. First of all, it was cheap, as cheap as 200 shillings, which was quite affordable. And in the event that the child could not buy it with cash, they could actually access it by doing some form of manual labor as a substitute for alcohol access. Then the other access point was the promotional trucks. So we have these, trucks that always make noise and they're promoting alcohol beverages. They often distribute these into the community free of charge because you're sampling, and some of the people who are accessing these are children. And then in addition, of course, we know the home brewing within our communities. So when we asked additionally about, among the parents who had children who are users, where do you go for help if you have a child that's a user? We found that most parents did not access any type of help for their children because they deemed alcohol or substance use as bad behavior. So it was seen as such. And so they did generally seek help for that. But among those that felt that this was extreme, you found that they expressed senses of helplessness, not knowing what to do, the stigma associated with accessing help, where people blamed you for having a problematic child. And so those sentiments ultimately hinder parents from seeking care for their children. So we went to the facilities as well to ask the question you asked, Judge, about are our facilities ready? And we found that only 1 out of 3 facilities were ready to manage substance use problems. The rest really weren't. And the biggest problem we have is the lack of trained staff who can manage these substances within facilities, as well as the underutilization of guidelines that can offer guidance for how to manage these substances. So I think the cake out of all our research is the opportunity that we gain from identifying children early, is that we piloted a screening tool that's child appropriate to help identify substance use among children. And what we found was that most parents were very positive about having children be screened within the health facilities because many of them did not know their children are drinking alcohol or using some substance. And so this then becomes the opportunity that if we can use our health facilities, our schools, as an opportunity to identify early use, then we can act early and ultimately influence the outcomes of the trend that's going wrong. So one of the key recommendations that I look at here is the one of integrating child-friendly substance use screening, not just in health facilities, because most people with substance use problems don't go to facilities, but they're going to schools, but they're also in the community. So we can use this as an opportunity. So the take-home message for us is this: we should consider screening early, acting early, to protect Uganda's next generation. Thank you.
Thank you. You can take a seat in front. Just that in the event that they allow us 1 or 2 minutes for Q&A, that can be addressed. Thank you so much, Harriet, for that presentation. Allow me welcome the second presenter. That's Anne-Mathe Solheim-Ska, who is the Director of Cluster at the Norwegian Institute of Public Health. She is also the PI of the Treat Interact project that is housed at McChs University School of Public Health. She will briefly talk about Treat, but also share her experiences in multisectoral collaboration in advancing mental health. So over to you, Anne-Mathe.
Thank you so much. It's a pleasure to be here. And I am part of this Treat consortium. You heard Dr. Harriet present. Sorry, I need to move because I'm too low, so I need to see the screen. So she defended her PhD thesis only a few days ago. So that's one of the great outcomes from this Norway-Uganda collaboration. So we have, yeah. So we have worked together in this consortium for close to 10 years. And before that, even longer, a close collaboration between the University of Bergen, the Norwegian Institute of Public Health, and MakCHs University. So I want to acknowledge that collaboration, and we know from research that research collaboration across countries creates better research, more cited, more impact. So it's a win-win situation. So I will go very briefly through this first slide because we already touched upon many of the topics. Let's see. We will not use more time on the prevalence. We know there are high prevalences of mental health disorders globally in an adult population as well as in the child population. What we have a specific focus on in one of the TREAT projects called the TREAT Interact project is violence prevention. And that has also been discussed earlier as one of the key determinants of mental health challenges. What is good about violence is that it's preventable. So that's why we put a lot of focus on that. So one part of my position is at the Norwegian Center for Violence and Traumatic Stress Studies. We have a whole center dedicated to the prevention of violence. And that is because it is such an important factor in the health, both physical and mental health of children and adults. There is also a lack of prevention and treatment in so many countries globally in terms of mental health. And that's why we're very happy to have this session today. Many barriers exist, and we will try to go through some of these barriers in the coming minutes in what we do in this project. There is a clear need for action given the high prevalences, the high costs, and the suffering for the individual as well. So in the TREAT Interact project, we use implementation science to investigate how we could implement a task-shifting approach for child mental health promotion. That is, we develop intervention for teachers at primary school level, and that is because we know that early intervention is key in order to prevent mental health challenges. We train the teachers, we collect data on mental health, on implementation factors, and we do this through a so-called stepped wedge trial where we have 18 schools included. We randomize these schools to receive the mental health intervention at different stages. And we use the pre-intervention data as control data, and then we see, are there any effect along the way after training of teachers in mental health literacy, in stigma, in their ability to detect those in need for further services. So we are in the last part of the data collection as for now, so we don't have the final data to present today, maybe next year. So we collect data from teachers, also from caregivers and children themselves. So the aim, as I said, is to promote mental health, starting with the kids, but thinking that this will also have an impact on the teachers and the community. When we talk about mental health, we talk both about the need for prevention at the large-scale community level, and also treatment for those in need for the services. And I think this was very nicely addressed by previous speakers, that it's not like you have or have not a mental disorder. It is a continuum, and you might move out of one condition into another, or you could have healthy periods and then things happen, and that's life. So it's complex, and we need to focus on prevention while at the same time, of course, have available evidence-based treatment methods. So in the Treat Interact project, we would like to prevent mental health problems by increasing knowledge among the teachers, giving them the tools needed to identify children in need of mental health services, so that they also can refer those in need for the health system. So in terms of prevention, we have developed this manual for the teachers. We are doing the training of the teachers throughout the trial and then collect data before and after. In terms of the treatment they receive in the health facilities, we give training in the MakCHs program developed by the World Health Organization. We only have baseline data to present today, so I'll just briefly go through that. And this is the PhD work of my colleague Nora, who is sitting in this room. So she found an association between higher mental health knowledge among both caregivers and teachers, and also lower level of reported aggression towards the children. This is being linked to lower mental health stigma. So this is important data for us to work further on in the trial and hope that we could increase knowledge and decrease violence and stigma. She also found that corporal punishment and aggression towards the children, it was reported by approximately 70% of the children. This is linked to higher level of mental health challenges in the kids. Also, we see that there are discrepancies between what the caregivers themselves report and what the children report. And when there are these discrepancies in the perception of violence, this is also linked to higher levels of mental health challenges. So this tells us the importance of children's voice themselves in mental health work. The last paper in this PhD defense, which is soon to be delivered, so in a few months we will be able to clap for her as well. She did a meta-analysis and systematic review and revealed high levels of probable post-traumatic stress disorder rates across African schools. So with this project, we really hope that we will be able to close some of the gaps we see within mental health. It's a small project. It's only one step moving in the right direction, but we hope to develop knowledge needed to move forward within this field. There's an intervention gap, as we talked about. There's a service gap. There are different barriers to receiving help. And there's also a big data gap. Where there was a systematic review a few years ago on implementation studies. It was only a few percentages from low and middle income countries. So the majority of the implementation knowledge we have is from high income countries. We really need more focus on implementation. Of course, we need information as well on effective interventions that are developed in the context, tested in the context they are supposed to be used, but also focusing on how could this program be implemented successfully over time and with sustainability. So that was the closing from me. Here is the, let me see. So we will, just lastly, we will develop implementation guidelines that hopefully could be of use based on the results of the trial, which will be finalized by closer to summer. Thank you.
Thank you so much, Anna-Mathe, for sharing those findings and presenting the role of treating in advancing mental health care in Uganda. My next speaker is from Ministry of Education. I think from this entire session, we've noted that Ministry of Education has a huge role to play if we talk about mental health of young people and people in school. So ladies and gentlemen, let's welcome Ms. Rebecca Namakula, who is a Senior Education Officer in charge of guidance and counseling in Ministry of Education and Sports. And she's broadly going to share the perspectives of Ministry of Education in advancing mental health care in young children. You have many questions that have been addressed, so kindly address.
Good afternoon, ladies and gentlemen. My name is Namakula Rebecca. I'm a mother of 3 and a wife to 1 man. I'm happy to be here. Thank you, MakCHs University School of Public Health, and thank you, Ministry of Health, for inviting me. A lot has been said about mental health, the causes, the triggers. Mainly what I'm going to share with you. Technology, where do I press now? I need your assistance here. What I'm going to share is about what we have done or what we do as Ministry of... Oh, here, okay, thank you. Here? Okay. What we... This one. Okay. What we do as Ministry of Education and Sports, or what we have done. A lot has been done and a lot has been said about... I'm going to ignore all these statistics, maybe a few here, because a lot has been said about the prevalence of depression and anxiety amongst our learners. And to add on what Justice said, there are a lot of mental health issues in our schools. But as Ministry of Education, we are saying, we are not only concentrating on learners, but we are starting with the school staff, the head teachers, the administrators, these proprietors of schools, the warden, the askari, the matron, the cooks. You can just imagine if the cook is not okay upstairs, she can poison the food of the whole school community, and we may end up losing them. So for us, we are saying that we are looking at the whole school community, and we've tried to start with the administrators, the HMs, the school managers, because when they are mentally okay, they will take mental health as a priority in their schools. When the HM is not okay, he will transfer his problems to the teachers. And what will the teachers do? The psychologists here, we know our displacement as a defense mechanism. They will transfer the problem to the teachers, and then the teachers will transfer their problems to the learners. So we are building capacity of the teachers to help them to manage their mental health, but also to be in position to help the learners, because they cannot provide what they don't have. They cannot support when themselves are also going through a lot. So that is what we are saying as Ministry of Education. We are supporting the parents, we are supporting the teachers, we are supporting the learners. Of course, parents have to come on board. Like Justice said here, many problems stem from home. Dysfunctional families, divorce, domestic violence. And for those parents who can provide whatever their children ask for, they think that that is enough. The truth is, these learners, these children need us in their lives. Recently, there is a school I went to, I won't mention the name, it's one of the big schools. I had gone to talk to the S4 before they started their exams, how to manage examination anxiety. But after the session, all these students came around, they had many issues. These children were crying. I call them children because I'm a teacher. Yeah, they were crying. And most of the problems were stemming from home. Actually, one was even contemplating suicide. So parents here are providing money, giving money is not enough. These children need us in their lives. What are we doing? as Minister of Education. Of course, some policies are coming up, but to start with, we came up with Circular 20, we call it Circular 20, which we drafted in 2022. And this circular has very many things. What should be done in a school setting to see that mental health is being supported in a school community. We are talking about the mental health hour. We are saying that at least 1 hour weekly 1 hour should be put on the timetable to cater for mental health. We're not saying for learners only, but also the staff. It has very many contents. That is our circular. We are saying that in that circular, some of the contents in that circular, that at least we designate 2 staff members to be in charge of guidance and counseling to provide mental health. One of my colleagues said that we should make it a deliberate intervention to see that we put in trained personnel to provide the service. That is what we are also advocating for. We know that the people providing the service in the school, the senior men and senior women teachers, very few schools have been able to hire professional counselors or psychologists to provide the service. But now they keep telling us, Wejibiru, there is no money. Now we are saying as education, as we advocate, as we make a lot of kerele, we are saying that we will not just sit and see our learners perishing. We train these senior men and senior women teachers to handle our learners, the issues of the learners. But now the question comes, who will handle the teachers? Who is handling the HM? Who is handling the deputy who is very rough? Who is handling the warden, the askari, and the cooks? So we keep on saying that there must be this professional in a school setting to provide the service. And also to orient them. We give them the best skills. They are not professional counselors, they are not professional psychologists, but at least we give them a minimum of how to handle the learners. Then we form a guidance and counseling committee. And we are saying that these people who are providing the service in the schools, they shouldn't be part of the disciplinary committee. Because when they are part of the disciplinary committee, learners will not go there when they have issues. Because they will see them as judges, as people who are there to judge them. So we are saying that these people should be, the GIST committee should be a neutral committee, and members of that committee should not be part of the disciplinary committee. And we are saying that at least 1% budget of the school should be allocated to mental health. And then we map partners around the school community to see where we can seek help, because like we have said, we are not professionals, we as teachers, to handle. There are those difficult cases we cannot handle in school settings, but we are training these teachers to identify those cases and maybe refer. Actually, for us, we are using the term link. We don't refer, we say linkage, because when we refer, they don't go there. So we are saying we just handle them like this, and we pull them up to where they can get the service. Even the adults here, when we refer them, they don't go. So with these adolescents, we are saying we link them to the services. That is the mental health circular. Audio. Press for me. We also have that, a moment. We've also developed those materials. Like Minister of Education, our role is to provide information. So we've come up with some readers for our learners. Easy to read, that they can easily understand them. We have those for primary, which are mostly pictorial for them to understand. And then we also have for secondary. For the primary, call them My Mental Health, My Pride. And then for secondary, we say that Mental Health and Wellbeing Guide for post-primary students in Uganda. There is a treat they can understand. When they have issues, they are able to say, to identify that maybe I have this issue, I can go to here, I can go to so and so for help. We also have a handbook for teachers. Like I said, teachers cannot help when they also have issues. So we developed that handbook for teachers. It is also easy to understand even if they are not psychologists. Then we also have an online module. It is there on our website about mental health.
You can Google it there and find it. That is easy to read and understand. And anyone who is not even a psychologist can understand. For us, we are providing information. And that is my last slide. We are saying that we need to work as a team. I had some questions came here like, what is Ministry of Education doing about of course it came from lack of sleep, that children do not sleep. But I may also ask a question. These children come from homes. Why would a parent release a child at 4:30? I mean, you have a right to say that my child will not go at that time. Yes. Why do you say EE? Because if classes are starting at 8, why should your child leave home at 4:30, at 5? We should not point fingers, colleagues. What I'm saying is, everyone has a role to play. I personally, I decided my children do not start the holidays. They have to rest in the holidays. Even if it is a school program, whether they are candidates or not, they do not start the holidays. And they pass. So if you're a parent here and you're releasing your child at 4:30 and then you keep on blaming the Minister of Education, then I also wonder. You blame government. Who is government? Government is you and me. Yeah? Who is government? Like, we shouldn't point fingers. We should work as a team. Ministry of Health has a role to play. Education has a role to play. Gender has a role to play. Police has a role to play. Let us, all of us, let us play our roles very well. Then we'll be able to improve our mental health. God bless you.
Thank you so much. What I get from the presentation is that mental health requires all of government, all of people, all of society approach. And so integration becomes key. I think this is what we are going to talk about time and again. We have about, I know our time is fast spent, but I'll do injustice to all of us here if we don't allow time for some questions. So Bina, I'm going to allow only 4 questions. Please, I need only 4 people because our time is fast spent. So I'll take only 4 questions, and then we'll see if we have more time to take the other round. Yeah, you are the first. Okay, so who has the microphone? Who has the microphone? Please move it around. You are the first. Who is the second? You are the first. We need the second. One of him.
Who is the first?
Yes. And then this side as well. Who? Another side? There. Okay. And then one person the other side. So that's the first round.
Okay, thank you so much. And Hafsa knows me very well. You know my late sister, Dr. Margaret Mungerera. Many of you knew her. She said, even everybody has got a mental health problem. It just depends on the extent. And she always said that. Even when she went on the television, she said that. After diagnosing all of us in the family, including my poor mother and father, she always had a condition for each one of us. I realized one thing. We are working out in the fields, but diagnosis of mental health is a problem. You know, we work with, I've spent over 30 years working in the community, civil society with who. A person says, I'm not going to eat food, and they don't eat food for a week, and no one knows that is mental health. So as we are treating other diseases, we do not know how to diagnose mental health. So my issue is that we do not have people in the community, in the districts. That's number one. Number two is stigma. Do you realize that many children are kept away, locked up somewhere because of the stigma of mental health? So I'm suggesting that as you talked about nurses, psychologists, social workers, and those people who
Simon Civil Society. I would like to applaud the presenters. Really, this is exciting session we are sharing. My concern here is on diagnostic of mental health. I think the family-centered approach is very critical. I've seen the Ministry of Education have set very good strategies, but do the community understand that these interventions are there, these policies are there? As you tell us, not our children to wake up very early. You have made very good policies, even telling us not to go with food at school to visit children. But you announced it, the following visitation, we went with food. There was no action. The same thing when I don't take my child, we lose what those ones are grasping out. So we need to be policy makers and enforcers. If you say holiday, no education, let it be. You can't tell me I don't take my child when others are studying. Do we have a policy in Uganda? Really? If it is a policy, why others take them? And why others, you are telling them not to take? Schools are doing whatever they want at their own pace. I'll not take a lot of time, but I want us to have more discussions on these matters and this multi-sectoral approach with our judges, with our counselors, education like you. Let's continue these discussions and build a very bold policies and laws for the country to continue surviving. And we fight the prevalence of really mental health is too high. I can't say much. We can spend here the whole month. It's a big thing. Thank you.
Thank you. I think a comment and about policy implementation. You have one more there on the other side.
Yeah, thank you.
Really brief and short.
Congratulations, our graduate. And I was looking at aspect of the communities that the study was done in. And you brought it very clear, the exposure to the substance, family, separation, and curiosity. Then I was thinking, what about the urban-rural disparity? Was there any difference amongst the rural and urban or peri-urban dwellers? And then income level. Was there something related to that about the children maybe from the well-to-do families are the ones who are abusing this much or from the poor families? Then Minister of Education just tickled me about screening. I know that within the school communities, we do screening of many workers there. And those who are cooks, we screen them for other common ailments. Skin diseases, mention them. I don't know whether we do mental health screening because you brought something that tickled me. Because the head teacher or any other staff may annoy this cook who has a mental problem and will transfer the aggression, because they're emotional labor. I don't know whether that is done. If not, could that be a food for thought to inform our policy? Thank you.
Thank you.
Yeah.
One hand, the other side.
Yeah, thank you. I don't have any kind words for the official from Ministry of Education. The last person who spoke.
Who has the microphone?
Is here. I'm here.
Okay, all right.
Yes, this side. I don't have any kind words for Madam from Ministry of Education who last spoke. I never went to nursery, but I passed. I never did the holiday studies and I passed. Moreover, in a village school and I went to a government university and I passed and I'm here. So everything that was done in education those days has changed upside down. We are talking about mental health, our children are breaking down. You are the cause. You need to reanalyze your policies and implement what you say. What you presented there is a paper, but physically you do not do the right things. Thank you. I'm a health worker. I talk the facts.
It's about policy again, but please be kind. One more, the other side. There was one hand. Okay. All right. Then we allow time for the panelists to give comments.
Thank you. Good afternoon, everyone. My questions and comments will be mainly directed to Ms. Namakula Rebecca, Ministry of Education, Guidance and Counseling. One, you talked about having handbooks for teachers to help the students in the absence of a psychologist. Now, the teacher is trained to handle something very different. Something very, very different. So when you say that you have given them handbooks so that they can do the work of the psychologist, for me, you are implying that anyone can do counseling. And I think that is already questionable. And it is happening in our schools, and it is harming our children. When a child is suicidal, what is the teacher supposed to do with that child without training in mental health? What are they supposed to do? I have had a head teacher who boasted that he told a child who had tried to commit suicide and told them, go ahead, commit suicide. And then he asked the nurse, did she commit suicide? The nurse said, no. Yeah, that is how to treat them. But is it the way to treat them?
Thank you.
So, this handbook, if you are not giving these teachers training, please don't send them to the schools. You are harming the children. Two, paying professionals. You're saying there is no money to pay the professionals. Madam, I think there should be, you should be going back to the drawing board. This is a service that we need in schools yesterday. And you need to pay the people who are providing this service. Did they say they are Save the Children? No. They are here to do a job, and they expect to earn a living. And they are doing the job. Pay them. Let them do what they must do. When you talk about senior men and senior women teachers in schools, those roles are disciplinary. They have nothing to do with counseling. When they bring to you a child as a senior woman teacher or a senior male teacher, they expect you to give that child a punishment for whatever they did not do right. Is that what counseling is, madam? So let us put these things where they are supposed to be. We are mixing things, and we are comparing mangoes and oranges. Let us stop. Let us do the right thing. Thank you.
I think the point is, yeah. So you're going to respond? Okay. So that's it. No. We are not taking any more questions. We really, our time is fast spent. Let's allow time. Our time is fast spent. So, Rebecca.
Thank you very much, madam.
In 1 minute or less.
I will try. First of all, when I talked about the teacher's handbook, this teacher's handbook is known to help them counsel the learners. Actually, I have a copy. This teacher's handbook is to help the teachers to know more about mental health. We are trying to popularize mental health. Not very many people know what mental health is. I think you agree with me. So to start with, we are trying to make people understand what mental health is and appreciate it.
Give me that.
In a school setting, like I said, we expect teachers to support our learners. But these teachers cannot support learners when themselves are suffering. So we came up with this handbook to help teachers discover themselves, identify the issues they have, then they see how they can seek help and be helped. Then afterwards, they can be able to help the learners. This handbook also helps them to identify
the cases when they arise. Like they can be able to see the symptoms and tell, I think this child is going through depression. I think this child has anxiety. So the handbook, okay. Sorry. Does it help? Okay. The handbook, like I've said, maybe it's because of time and I was rushing through my slides. The handbook, this teacher's handbook, is to equip them with the basic knowledge of what mental health is. And when you have that knowledge, then you can be able to see how to seek help. Secondly, you talked about when a child is suicidal. Like I said, we orient these teachers. In a school setting, for us, we do not diagnose. But when we see the symptoms, we can say, I think this child has a problem. When a child is suicidal, we are telling these teachers to refer such cases. That's why we are saying that each school should be attached to the a nearby health facility. Of course, in a school setting, a teacher cannot handle suicide. You talked about pay. When you say you, what do you mean you? Me as Rebecca, me as Minister of Health? I think I was very clear. We are advocating, we are lobbying and saying that each school should be with a full-time psychologist or school counselor. My commission has written, I don't know how many concepts. But when it reaches Minister of Finance, of course, they say wage bill. And you can attest to what I'm saying, that not even all schools have school nurses. Yes, some schools do not have school nurses. But we are saying each school should be with a school nurse, each school should be with a school counselor. When you say when Minister of Finance does not release money, do you want Rebecca to get money from her pocket and pay these school counselors or what? What some schools have done, before we go to that, they have been able to employ, to recruit their counselors paid by the school, not by government, to handle such issues. Like I said, we already have a structure in place according to our educational policy act, educational act. We have senior men and senior women teachers, and we are using this structure. We are orienting these teachers. We are providing them with a basic knowledge. Of course, we've just started. Actually, all of these materials were developed last year and some this year. And we are trying to orient the teachers regionally. Last year, we were able to go to some school to get some teachers from the East and Central. This year, we're planning to do North and West. But of course, with the little budget we have, we've not been able to reach all the schools. Thank you very much.
Thank you so much. Work in progress. We need a whole day to discuss mental health, I think so. Next time. So
We shall ask for a whole day, Wanange, because
with that, the rest were comments. My panelists, let me allow my panelists to go down. Let's give them a mighty hand clap for the very good presentation. Thank you so much. And I will hand over to Dr. Hafsa. My time is also up.
thank you very much for the time well spent. Thank you very much, people, for listening in. Thank you very much for your comments. I'm seeing people living like there's something to be done. That is so wonderful. We have tickled you. You need to do something. It starts with me. It starts with you. Before we end, kindly give me just 5 minutes. I cannot invite a whole big dignitary and just sits in here to do nothing. I'm just requesting that let's listen in. I'm giving her 5 minutes from the IGG to say something about mental health and speak to us. Thank you. Just kindly give us some 5 minutes. Dr. Kalani, kindly give her the microphone. Would you like to come over to the podium or you want to speak from there? Kindly, thank you. Thank you. Just 5 minutes, don't worry. It shall be done. Wonderful. Thank you.
Thank you so much, Doctor. Is this working? Thank you. Thank you. I was telling the doctor I would do less than 5 minutes because I'm sure everyone is already burnt out. I don't want to try your mental health. I want to thank you, Judge, for inviting me to come and listen in to this very critical and very important topic on mental health. This, we take mental health issues for granted. And of course, from our societies, the African society, it's a taboo to talk about some of these things. But the impacts are fundamentally on our output and on what we do, or how we serve society. So I am happy that there is such a forum where we are discussing these issues. I also know that the issues of mental health cut across. They cut across in different sectors. I was discussing with my colleagues I was seated with, we're thinking about you health practitioners. You put in so much, you give in so much to the society, you know, to deal with our issues. And we're wondering who deals with your issues. In fact, I was sharing with them, who deals with their issues? I was sharing with them that little wonder we go to health centers and you see some of what your people, doctors, do in the health sector, and then you're thinking, no, there's a problem here. There must be a problem upstairs. It is something that I have discussed with Diana. I've told her in the past to find a solution, to find a solution for you, our people. It's not enough for us to insist on limited resources, because you'll be insufficient if we don't proactively address the issue of mental health. So I was looking at, and doctor, you can take it from here because you're the one who is here. You look at ways of addressing issues that affect our colleagues in the health sector very seriously, because I know that once we address these issues, then the environment will be conducive for everybody, everyone else, to avoid the issues, the impact that comes to our society when we don't deal with these issues. Of course, there's a correlation between mental health and the ethical values that we have in society. You have seen that there is an increase in we are poorly rated as a country when it comes to issues to do with corruption. And it also has a nexus with mental health issues. Because you look at the things people do in society. For me as an investigator, I'll tell you, and I'm happy that the judge gave you some examples. Off the cuff, I can think of some 2 cases where people have done things, and I'll give you one in the mental health, in the medical field. We had a case in Masaka, I don't know whether you saw it, where a doctor in theater refused, Masaka Referral Hospital, I think I sent the matter to the medical board, refused to attend to a patient because they needed to be given 300,000 shillings. And he dared the patient. I said, "Olaba omwana wo yagenda kufa. Bonoba tolese sente mitwala sa." Don't you think there's a mental issue there? Is it just about the money? Is it just about the 300,000? And guess what, doctors? That child died. You Google, you will see this story. It's there. It's on the internet. So I know that if we handle this, if this discussion is taken seriously at all policy levels, then we'll go a long way, not just to help our citizens, but also to ensure that we improve service delivery in our country. So I want to thank you for helping me to be part of this discussion. And I pray that in future you invite different, even us as stakeholders, because when I come, when I'm more organized, then I'll be able to give you many other stories where we have been affected. And now this triggers my mind to think even outside the box, and not just to look at the punitive ways in the fight against corruption, but also to think about the mental well-being of these individuals that we deal with in society. It's important. It's important because the kind of greed or the level at which we are as a country shouldn't be comfortable for any of us, and it should stir some thinking and intentional, action on all our part. Please think about that. Think about the mental wealth being vis-a-vis the nexus. I think it should be the next topic in the fight against corruption, and we'll be happy to contribute to that topic when the time comes. I thank you.
Thank you very much. We are getting people on board and so very happy. I've also been told that the media wants us to be engaged or wants us to engage them so that they can be the link between, they can broadcast the messages around mental health, but also on NCDs. Our call to action. By talking openly. Okay. Our call to action. By talking openly and supporting each other and seeking help when needed, we can create a more inclusive and mentally healthy society. That is what we are calling for, and we have to be intentional in doing this. I thank all of you for listening to us, and I call upon you to this be your first step in improving your own mental health, but also the mental health of the people around you. So with those many words, I want us to end here. I have been promised, yes, I've been promised that we shall have another day for mental health. And we are inviting you again and again, please, when you hear mental health discussions, mental health dialogues, please come up with your issues. Dr. Oyo, I don't know where you are, but the media is calling on us. We want to give a vote of thanks. You're giving a vote of thanks? No? In the afternoon. Okay, so I'm being told that there's another discussion going to happen this week during this conference. It's going to be on Thursday in Mira Hall, and we are going to talk about mental health in the workplace. And I think it touches on all of us here. So before we really go, I want us to have a group picture. A group picture. Those of you who are here, we take a picture with the judges, with the IGG. Hey, and we feel happy. It is part of our self-care. So colleagues, stand up. Let's come for a picture. There's no music, but for us in mental health, we really love to dance and be free. So thank you very much. I wish there was some music to keep us going. Colleagues, there's going to be another meeting here. So those of you who want to take part in the pictures, guest of honor has to be there. Guest, kindly be there. Stand down while others will stand up. So please, those of you who want to take part in the picture, kindly come up. There's going to be another meetings, and actually we are leaving this room. So until we meet, until we meet again on Thursday, I want to wish you fruitful deliberations for the rest of the week.
Okay. I'll wait for you.
There's a chance that my head will be seen. I was on the microphone.
Okay.
Let me also have the opportunity to stand next to this one. I don't know what.
Okay, thank you. Colleagues, you can give a big hand clap to our guests for that session. We have a place for more group photos outside. So the team, you can continue and have group pictures outside. So as you move out, ladies and gentlemen, we have a roundtable discussion coming up, but this is for the invited chief of parties and the civil society organizations. Please stay behind, and we are going to be having a meeting taking place now. We expect to have JCRC, TASO, AIC, Beira, Uganda Cares, MJAP, Uganda AIDS Commission, representatives from the US government and World Health Organization, executive directors from the regional referral hospitals, and a representative of the CSO, Flavia, and your team, and also a representative of the people in care. Please stay behind, together with a team from the Ministry of Health, led by our commissioners and the technical officers from the HIV and TB program. Please, we request that you take the front seats, and this session is going to be chaired by Dr. Stavia. So as others move out, please that you stay behind. We have been informed that, yes. We have been informed that please take care of your bags. Take care of your bags, watch out. We already have an incident reported of a missing bag. So please pay attention to your bags and your laptops. And if you carried a bag by mistake, you can report to the secretariat so that it's handed over to the owner. So colleagues, let's give space for the next meeting to start. For the people that have been mentioned, represented by your chief of parties and the directors from the regional referral hospitals. So the rest of us, let's meet tomorrow, same time, for the day 2 activities to begin. Thank you for coming. Yes. So members, let's take our seats for the meeting to begin. The chairperson for us, let's come in the middle. Our round table is going to be here in the middle where you see Dr. Savia. So the eyes, let's meet in the center. And the ushers at the back, please help us maintain the door. Maintain the door. The media, you can leave. This is an in-house discussion. So the media team, you can leave. This is for the people that have been mentioned here and from the organizations that we have mentioned. The rest of us, we shall continue the meeting tomorrow. The IT team, I request for 2 microphones because we are going to use the downer part, not the stage. So colleagues, let's take our seats. Let's take our seats. Those having discussions, we can continue outside. We want to call the meeting to order. Let's take our seats. We need to come together. We are using the first 2 tables here in the middle. The Ministry of Health technical officers, Kato, help me mobilize the team. We are taking these 2 tables here. Other people can continue with the discussions outside. Let's have the meeting begin here. We are using the tables in the middle. And again, just to emphasize the invited people for this meeting, we expect all the IPs, their representatives, the civil society representative, directors from the regional referrals, and also the Ministry of Health team led by the commissioner and other technical officers. So people at the back, kindly give us some time to start. Kato, you can mobilize people at the back and we start.
This is not our agenda.
Thank you.
Thank you, our moderator for the day. Cordelia, you are sitting very far away. I don't know where the other technical officers are. I'm not seeing them. Mutumba, where are they? So, wow. From prevention to, I'm not seeing them, but that's fine. So I want to take the opportunity to welcome you to this discussion. They said round table. I don't know how round this is. It is horseshoe. I hope we wanted to be looking at each other's faces, but I see some people are looking at other people's backs. So, but in the interest of time, we shall start. The agenda for our session, I think we will need to know each other. We assume we have prayed since we started, since we are joining a session that has been running. Then we'll have a brief from the Ministry of Health. Then we'll have a brief from the Centers of Excellence. The recipients of care, you can have a joiner there. Then we'll have a discussion.